I propose that we now go into public session. Is that agreed? We are now in public session. This morning the committee is meeting with representatives from the HSE and Cervical Check to receive an update on Cervical Check programme, and in particular the committee has expressed a particular interest in hearing in relation to the proposed introduction of HPV testing for cervical screening, and also to discuss the issue in relation to delayed smear reporting. So on behalf of the committee, I would like to welcome Mr. David McCallion, National Director, Screening Services, and Dr. Colm Henry, Chief Clinical Officer. Also Ms. Michelle Tate, HSE Implementation Lead for the SCALA report, and Lorraine Doherty, the new Clinical Director for Cervical Check. Thank you very much for coming this morning. I wish to draw your attention to the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect to their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise you that any opening statement you have made to the committee may be published on the committee's website after this meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. Can I now call on Mr. McCallion to make your opening statement, please? Thank you.
Thank you, Chair. Good morning, Chairman and members of the committee. Thank you for the invitation to attend the committee meeting. I'm joined by my colleagues Dr. Colm Henry, who's the Chief Clinical Officer in the HSE, Dr. Lorraine Doherty, who's the new Clinical Director for Cervical Check, and Ms. Michelle Tate, who's the Implementation Lead for the SCALI report. The HSE remains extremely conscious of women's concerns regarding cervical screening over the past year, and in particular many women's anxieties due to the delays in reporting on smear test results. The HSE is doing its utmost in order to find solutions to these waiting times, and we apologise again to the women for these delays and for any upset that has been caused. We continue to address and manage the vast range of issues that have emerged as a result of the crisis in the Cervical Check programme last April. Our priority areas include stabilising and strengthening our cervical screening programme, continuing to support women and families who were directly impacted by the Cervical Check crisis, implementing Dr. Scali's recommendations, strengthening the governance arrangements, enhancing the quality assurance of the programme, and advancing the implementation of HPV primary screening. The report circulated previously to the committee updates on these key areas of priority. Supports to women and families. Our information line continues to provide information to women who are understandably anxious at delays in accessing their results. We also support women and their families in the provision of access to their records and ensuring women get their slides from laboratories where required for legal review. The Client Services Unit in our National Screening Service continues to support this process, and to date 118 out of 125 requests have been dealt with, on average in 27.5 days, and there are 7 requests currently work in progress. We continue to support the women impacted through the 221 group through our Community Liaison Officers. The Community Liaison Officers support women and their families in provision of the support packages provided to government. We are also developing a public and patient inclusion plan for our screening services. We've established a patient panel for cervical screening that already has provided critical input into aspects such as communication and Dr. Scali's initial recommendations. We've also brought patient representatives onto a number of key project groups within our screening services. We are very grateful to the many patient representatives who voluntarily give up their time to support our screening programmes. We have made a start in this area and remain committed to bring patients to the centre of our screening programmes. The independent review, we are continuing to support the independent international expert panel review been undertaken by the Royal College of Obstetrics and Gynaecology, which was established by the Minister for Health for women who were diagnosed with cervical cancer. The HSE supports the consent process, established a National Help Desk and has developed an eligible data set with the National Cancer Registry and implemented a client management system to support the RCOG in their work. In recent weeks, the laboratories have commenced the transfer of slides, and the ORCOG estimated it will take 6 months to conclude. Programme turnaround times. In 2018, around 370,000 women presented to the programme, an increase from 280,000 in 2017. This is an increase of around 90,000 in total. We remain concerned at the length of time been taken for reporting of cervical smears. Over half of samples received have been processed within 15 weeks, although it can take up to 33 weeks for the report to be provided, and there is a backlog of 79,500. We have worked with existing private providers, other private providers and public service providers in other countries to try and grow our laboratory capacity. Some of our existing providers have managed to reduce the wait times, and we continue to work with others to try and find additional capacity. While we continue to pursue active leads, this has proved very challenging due to the global shortage in cytology. This has been caused as a result of the reduced cytology requirement as countries implement HPV primary screening, which sees a reduction of around 80% for cytology requirements with that programme. We are actively trying to identify possible solutions that would reduce those wait times, which we know are causing a lot of anxiety for women. While this is very undesirable, our clinical advice is that this still poses a very low risk to women. Notwithstanding this, we recognise these delays are extremely difficult for women, and we are making every effort to improve this situation. We have made significant improvements in the turnaround times with 2 of our 3 laboratories and are working closely on an improvement plan with the 3rd laboratory. We are absolutely focused on reducing waiting times for results as quickly as possible. Laboratory services. A key risk to enable cervical screening to continue in Ireland was the extension of the laboratory contracts. The HSE signed agreements with both providers to enable continuity of the programme. The HSE also made a decision to expand the public laboratory capacity. An agreement was reached with the Coombe Women's and Infants University Hospital to do so. This will provide a better balance between public and private laboratory capacity provision. An initial capital allocation was made to develop the National Cervical Screening Laboratory at the Coombe. A project steering group and project team are now in place, with building and workforce plans being developed. While we are planning for a rapid building programme through a modular development, it will still take a number of years to implement, primarily due to the workforce challenges. HPV primary screening. We are progressing plans to introduce HPV primary screening. A project team is in place and is progressing the 7 work streams involved in the projects. We've completed a review of international HPV primary screening implementations. The review informs us that our critical path will be the availability of a provider and the timescales to implement the IT systems to support HPV primary screening. Furthermore, ICT testing is underway, development of education training materials has commenced, and our procurement team have started the tender process for laboratory services, with a pre-tender market engagement session held before Christmas. A contract notice is about to issue, which will seek formal bids from laboratory service providers. Our market engagement has identified significant challenges and concerns in the provider community that we are addressing as we move into the tendering process to ensure we are successful in acquiring a laboratory service provider. We remain committed to implement HPV primary screening as soon as possible, with the critical path to be determined by the tender process that is underway. Dr. Scali's implementation. The HSE has contributed significantly to the development of an implementation plan in collaboration with other state agencies in response to the Scali review recommendations. We have appointed a senior manager, Michelle, to oversee the implementation and established a HSE implementation oversight group jointly chaired by the Chief Clinical Officer and the Deputy Director General of Operations. We have developed a set of 101 actions arising from recommendations that are the responsibility of the HSE to implement, and we are reviewing appropriate actions against each recommendation as the implementation progresses. Examples of progress to date include key appointments and governance changes. An organisational review of risk management structures has also been commissioned by the HSE, in addition to the establishment of an expert group within the National Screening Service to review clinical audit processes across all screening programmes. An interim revision of the HSE open disclosure policy has been completed and approved by the HSE Directorate, and the process of communicating this and ensuring its implementation throughout the system will commence in the coming weeks, pending a more detailed review in late 2019. The HSE has also reviewed and updated its National Financial Regulations policy in relation to procurement documentation. All 6 recommendations from Dr. Scali's interim report have now been fully implemented, resulting in significant improvements in the information and supports provided to women and other service users in relation to our cervical screening programme. The HSE has maintained open communication with patient representatives in relation to the implementation plan and will continue to work collaboratively with them throughout 2019. Programme governance. We've continued to strengthen the governance and management of our screening service. We established an interim management team in the National Screening Service with the reassignment of senior people to key positions while we fill these positions on a permanent basis. We've recently appointed a Director of Public Health, Cervical Check Clinical Director Lorraine, and a Cervical Check Laboratory Quality Assurance Lead. In addition, a risk committee for our screening services, which is independently chaired, was put in place in Q3 2018. An interim quality and risk manager was also appointed in Q3, and implementation of Dr. Scally's recommendations on strengthening our quality assurance processes has commenced. We've also identified a number of priority positions for implementation, which are currently going through the approval process. I can assure members that the HSE is absolutely focused on stabilising the cervical screening programme and hence enabling us to progress the introduction of a new enhanced HPV primary screening methodology. All possible resources have been directed at this challenge. Finally, following the recent untimely death of Laura Brennan, I would like to take this opportunity to acknowledge Laura's work in promoting the HPV vaccine and the importance of cervical screening. In the most difficult of personal circumstances, I had the privilege to meet her, and I know that she was an inspiration to us all through her dedication, bravery and humour. We all have a responsibility to take up her crusade to eliminate cervical cancer in Ireland. Our thoughts are with her family and friends at this most difficult time. This concludes my opening statement, and together with my colleagues, we will endeavour to answer any questions you may have.
Thank you very much, Mr. McCallion. We're now going to open the meeting to our members. So I propose that our permanent members would have 10 minutes forwards and back, and our non-members would have 5 minutes forwards and back, and you'll all get an opportunity to speak. So our first member is Deputy Stephen Donnelly. Thank you.
Thank you all very much for your time and for your detailed submission. I know you're all working very hard on trying to clear up some of the damage that has been done to what appears to have been one of the most successful screening programmes of its kind anywhere in the world. I'd like to start with accountability and then move into some of the waiting times, what's being done, and I'd also like to look at the waiting times for colposcopy. So while there's been a lot of focus on the number of women waiting for test results and the amount of time they're waiting, there hasn't been as much focus on women waiting for access to colposcopy, because obviously referrals have increased there as well. So where are we at? There's about 80,000 women waiting for test results. Some are waiting more than 8 months. Referral for colposcopy has increased in waiting times. My understanding has increased. The HPV test, which was due to launch last September, appears to have been delayed indefinitely. We don't have a date. It's still as soon as possible is the language being used. And we know that this was largely due to the offer of the free out-of-cycle test, because we had this 90,000 additional tests which essentially overloaded the system. So what do we know? We know that on Wednesday the 24th of April of last year, the story broke from the steps of the High Court. And we know that on the Friday, so 2 days later, in spite of having never met the senior management of Cervical Check, the Minister said publicly that he had no confidence in them, and we know that this was interpreted by many as there being a problem with the programme itself. And we know that the following day at about 4 p.m. the Minister tweeted this offer of a free out-of-cycle smear test. Now, to this day, the Minister maintains that the offer of the test, the announcement of the test, was made, and that before it was made, there was no clinical advice to not do so. He has stated that categorically. He said in a PQ response to me just 3 weeks ago, neither I nor my officials received advice that recommended against these tests in advance of the decision. And indeed, he went further in the Dáil when he said, to those who persist in saying that I acted against official advice, that is incorrect, they have misled the Dáil. So that's a pretty strong position from the Minister. Now, yesterday we received a submission from Dr. Gráinne Flannelly, who was the clinical lead at the time. Dr. Henry, you are referenced in her submission. And what she says directly contradicts the Minister's position. And what she said suggests that the Minister has in fact misled the Dáil for the second time. He misled the Dáil on the Children's Hospital and has apologised for doing so. So here's what we now know. that at lunchtime on the Saturday, the Department of Health called the National Screening Services after a meeting that Dr. Henry you were at. You were in no way implicated in advice. You're just referenced as having been there. Dr. Flannelly said that Mr. Charles O'Hanlon, who was running the National Screening Services, got a call from the Department of Health regarding the offer of the out-of-cycle test. She goes on to detail that she then met with Mr. O'Hanlon and, in the strongest possible terms, advised against the test. Not only that, but she predicted what would come to pass. She predicted what we are all dealing with here today. She said that the laboratories would not have sufficient capacity for cytology if the offer was made, and that this would lead to longer waiting times. She predicted that colposcopy would not have capacity to deal with the additional referrals. This has come to pass. And she says, and I quote, "Most importantly, it would fundamentally undermine the screening programme," which is exactly what this ill-advised offer, did. Now, critically, she says that Mr. O'Hanlon called the Department of Health back within the hour, which was before the Minister tweeted his offer, which happened at 4:13 p.m. So we have very detailed evidence from Dr. Flannelly stating that the Minister and/or his officials at the Department was advised by experts, the National Screening Service, not to proceed, that this offer was made before any announcement, and we have a timeline to back that up, and indeed that the advice predicted the fundamental undermining of the programme, which is exactly what has happened. At an official level, I'm not asking you a political question or to peer inside the mind of the Minister. At an official level, would you accept that expert advice, that clinical advice, was given to the Department of Health before the decision was made to have the free out-of-cycle smear?
So I'll ask my colleague, maybe Dr. Henry, just to respond in a second. Just one general point maybe first is that in terms of the pressure on the programme, it's about 2/3 approximately in terms of the out-of-cycle smear and about 1/3 from women who've re-engaged with the programme or new women. That's a positive thing, but unfortunately in the circumstances we're in, that's created pressure that's there. So that's probably one important point of context in relation to the overall pressure and positioning the out-of-cycle smear relative to the other impacts that have come on the programme as well as a result of the crisis. So maybe Dr. Henry will just comment on the other aspects.
Yeah, thank you, Deputy Donnelly. Like you, I became aware of Dr. Flannelly's advice last night when I got her statement. So, like most people, I became aware of the announcement of the out-of-hours smear when it was announced publicly. And what I would say is that while as a doctor I understand screening and I understand the rationale, the balance between risks and benefits, and that the addition of out-of-cycle smears tilts the relative worth or value of a screening programme in one direction more than another. What I do remember also at the time was a huge amount of public anxiety. And when we set up our phone line around the same time, we were inundated with calls and couldn't keep up with calls. We know general practitioners were inundated with women who were anxious about screening. There was a great deal of misinformation and misunderstanding, and that was reflected not just in the way that women engaged with their general practitioners and called helplines, but also reflected in reporting and indeed at political level too. So while I understand screening and the justification for in-cycle and out-of-cycle smears and what that means, I think it is reasonable looking back to judge any decision made in the context of the time and the great deal of anxiety that prevailed at that time amongst women in Ireland, and the misinformation and misunderstanding about screening.
Yeah, certainly the context is important. Would you, nonetheless, obviously it's important to be led by clinical and expert advice on these issues. And indeed, as has been referenced by Dr. Flannelly, over-testing has no medical benefit. And in fact can tilt into harm for a screening programme. Would you say that's fair?
Well, all screening programmes, and I visited Public Health England recently, Deputy, and they ask questions themselves about their screening programmes and about new proposed screening programmes. And the fundamental question always is, when you're subjecting a healthy population to a test, is are you going to do more good than harm? So all screening programmes, which involve, after all, populations and not people who are unwell, involve that balance between creating value, reducing harm, and avoiding inflicting harm. So,
I think,
and the balance of intervals is calculated.
Yeah, no, I appreciate this. There's time. Dr. Harty, maybe a question for you as the clinical lead. Would you believe that there is a medical benefit to the offer of the outer cycle test?
Okay, thank you, Deputy, for your question. And as you know, I've recently arrived in the cervical check service. I wasn't involved in the decision-making around this at the time. Nevertheless, what I can say at the time, we were dealing with a very difficult situation in relation to confidence in the programme and anxiety among the population of women in Ireland who are concerned about the previous result of their cervical smear and what that might mean for them. So when you're working in a crisis situation, often you have to take decisions that you wouldn't take in the context of
I understand the context and the political context.
And I think,
I'm asking you a medical question as the clinical lead. Is there a medical benefit to an outer cycle, to a shorter interval?
well, the medical benefit can cover a range of benefits, including psychological benefit. And where there is any issue where distress or stress is caused to a patient by a perceived lack of intervention, it behoves medical practitioners to then decide what would be the most appropriate intervention to undertake. In this scenario, the decision was taken collectively in government to offer women the opportunity to avail of a free smear, which is particularly important for women who may be anxious and could not afford to actually pay for an additional smear. So decision-making at that time was a decision taken at a point in time when the service was in crisis. Ordinarily, we would not advise for women to have what we call out-of-cycle smears unless there is a very good reason to do so.
Thank you. Mr. McCallion, as the acting head, would you accept at this point, given the submission we now have, that the decision to offer the out-of-cycle test was taken contrary to clinical advice provided by the National Screening Service?
Well, in terms of the timing, Deputy, I think as you said yourself, I wasn't there at the time in terms of the timing around it. We only got sight of the submission late last night in terms of that you're referring to there. I don't actually have a copy here. I think it was tweeted somewhere. So I think in terms of, from our perspective, I think both Dr. Henry and Lorraine have set out the view from the programme's perspective. The timing and so on really is not something that we're focusing on. I mean, my focus, to be blunt, is really on trying to ensure we restore credibility in the programme. We try and find capacity to deal with the backlog and try and look forward in terms of how we resolve the very many issues that we have in front of us.
Thank you. One last question, Chair. I know I'm at the limit of the time. On colposcopy, there's a lot of data has been provided about women waiting to hear back on the test result. What's the situation in terms of waiting times and numbers waiting for who have been referred for colposcopy? Due to, as part of the care pathway for the screening service as opposed to for other reasons.
So just maybe make a general comment and I'll ask Lorraine then maybe to speak for a moment in terms of more specifics. She would have met with the colposcopists as recently as yesterday. So in broad terms, colposcopy services are under pressure. The performance in terms of the turnaround times is still good, and that's on the basis that extra sessions were put in place in anticipation of HPV. But that's not to say that the service isn't under very significant pressure. It's seen a significant increase from GPs in terms of referrals, and obviously women themselves are anxious and going to general practice. And that's led to an increase. I think Dr. McKenna, in her last appearance in the committee, discussed some of the solutions that we're trying to look at there. So I'll maybe ask Lorraine just to speak to that for a moment from her experience yesterday.
Okay, thank you for your question. If I can just update you on a meeting I had with the colposcopy community yesterday, which was the first time I've met with them since I took up post. And what I heard from my colleagues was the commitment they have to delivering a first-class service to the women of Ireland. However, they are under pressure from the increased level of referrals from primary care and elsewhere into the programme. What I've seen from the data is that colleagues have worked to increase the number of clinics available in most of the centres across Ireland, particularly in ones that would generally see a lot of patients referred for colposcopy. In some cases, doubling the amount of sessions or increasing by at least 1 or 2 sessions a week. So in terms of what the data is showing is that the waiting times are not abnormally high at the moment. But we do need to look at how we're going to support this going forward, because the additional capacity is being delivered in the context of goodwill and support within hospitals for delivering this programme. So we need to continue to support our colleagues in delivering that service.
Can I just ask on a point of clarification on that?
Just ask a question,
yeah, thanks, Chair. Yeah, it's very quick. So if I understand you correctly, Dr. Harty, the waiting times for colposcopy, to see a colposcopist now, you're saying they have not gone up in the last year, is that correct?
Well, from what I can see from the data here, that there's a target for 90% of women to be seen within 4 weeks of referral. In the majority of centres, that ranges between 100%, 100%, 86%. So, reasonably good, achievement. And then that obviously is much better for when we get to, after 12 weeks. So in terms of the performance of the service, I think what we're seeing is a service that is sustaining quite intense pressure, but nevertheless seems to be coping reasonably well for now.
And you don't have a sense, just
add to that, if I could, Chair, it's probably important for both Deputy Donnelly and others, is that notwithstanding that, I think, as Lorraine has said, there is significant pressure on the service. There's a lot of work to be done with GPs, and it opens up, I suppose, as Dr. McKenna said in her last appearance, in relation to looking at gynae services and other services and the model of working. The other point is that we have commissioned impact assessments through Dr. McKenna, who heads up the Women and Infants programme, to prepare ourselves for HPV screening, which will result in a spike of colposcopy referrals on a very phased basis over a number of years, and that's involved visiting each unit, looking at the issues in the unit, both short-term and long-term, and trying to see what resources we need to put in place to address that, including how we can re-engineer some of the pathways for patients, for GPs particularly. So that process is fairly well advanced. I think they've now visited around 75% of the units, and they will be coming back with a set of recommendations about how we can strengthen that service.
Thank you.
Thank you very much, Mr. McCallion. Now, Deputy Louise O'Reilly.
Thanks, Chair, and thanks to you all. And I obviously want to join with Mr. McCallion in expressing sympathy to the family and friends of Laura Brennan. She did fantastic work, absolutely fantastic campaigning work at a time in her life when most of us just wouldn't be able at all. She took on the mantle of that, and she will be always remembered for that and for the great work that she did. I'm struggling with this, and the reason why is the pathway of communication between the HSE and the Department of Health. It's very clear, and I fully appreciate you only got this last night, and as did we, but it's very, very clear that advice was given, which should, in my opinion, have made its way to the Minister. And yet, here at committee on the 13th of February, Mr. Breslin was happy to confirm that the advice didn't get, what he said is the advice didn't get to the Minister, and indeed the Taoiseach doubled down on that the very next day. So, could you outline for me, maybe Mr. McCallion, when clinical advice of the nature communicated by Ms Flannelly makes its way from the HSE to the Department of Health, is there an expectation that action will be taken? Because from her submission, she strongly advised, and all of the things, by the way, that we're here discussing, so as it turns out, she was right, that GPs wouldn't be, that weren't organised, that labs wouldn't have capacity, that the colposcopy services wouldn't have capacity, and that it would, and this is the worrying thing, that would fundamentally undermine the screening programme. So that advice was given to senior people, came from senior people in the HSE, to the department. Could you just outline for me, when you're communicating advice of that nature, how do you ensure that it gets to the right person? Because it clearly didn't on this occasion. Or it did, and we were misled. So I just need to try and understand that.
I suppose, Deputy, the challenge for us is we can't account for what happened at that time in terms of the detail, and I suppose the detail of that issue is probably one the department can clarify around it. I mean, what we can talk about as we have is just broadly speaking what's brought the pressure into the programme in terms of both the out of cycle and those women that have re-engaged.
No, but it's but it's very clear what brought the pressure onto the programme was the tweet from the Minister, advising that, notwithstanding the fact that no homework was done, no effort was made to address any of these concerns, that all women were offered an out-of-cycle test to reassure them. So, I mean, clearly he was acting against advice given to people in his department. So I'm asking what you understand as a senior person in the HSE happens to advice given by the HSE to the Department of Health. Because if nobody in the Department of Health is listening, or if the advice is being ignored, well then I think we have a serious issue.
Well, I suppose it's difficult for me, Deputy, to appreciate in the sense, A, we weren't there at the time, but also in terms of, in general terms, clearly it depends on the circumstances of that advice. If it's on policy matters, they're matters for the Department. If it's operational matters, they're matters for the HSE. We obviously offer advice in terms of, we have dialogue with the Department across lots of settings, both formally and informally. And you know, they will always consider that advice, and as I say, it depends on the context, whether it's a matter, an operational matter or a policy matter. All I'm really flagging in this case is that, you know, Dr. Flannelly sent in obviously her submission and set out her understanding at that time. Again, we have set out, I guess, how we saw the decision at the time, the context for it, but we were not aware of how that dialogue then happened from there, and the Department have obviously set that out to yourselves previously. It's not something that we can clarify here today.
But you wouldn't have a view about that advice being ignored?
No, well, I think we've set out, I suppose, the context, but, you know, in terms of...
Look, we all understand the context, but we're dealing now with a massive backlog, and women who are waiting because of a decision that was taken to offer repeat smear tests without doing any homework whatsoever. And we now find that, contrary to what the Minister said, that there was advice given. And I'm trying to understand how that advice would make its way from the HSE into the Department of Health. And what you're saying is that you have effective lines of communication. And what I'm clearly saying is that they're not working.
And I suppose, again, we saw this last night in terms of Dr. Flannelly's note. All I'd say in general is that where advice is given, the decision-making rests on whether it's a policy matter or a matter for ourselves. We're trying to focus, I guess, on solving the issues we have in terms of the backlog and the capacity. In general terms, we have lots of dialogue with the Department on all sorts of issues on a daily basis. And as I say, the decision-making then either rests in terms of policy or operational matters. Obviously, Gráinne, Dr. Flannelly set out her understanding of it at that time. I can't comment on that in terms of the sequence or timing. I wasn't there. And I think, as Deputy Donnelly has said, there's been responses already from the Department about how that operated. So I'm not really in a position to get into the specifics.
Would you be happy that the advice that was given in this submission was relayed to the Department in any event? I mean, she clearly says that Mr O'Hanlon relayed it. So would you be happy that the advice made its way there?
I can't confirm, or, you know, I wasn't there. I would obviously take Dr. Flannelly at her word on it, but I can't comment on it in terms of, you know, we weren't there at the time and so on. Okay.
So with regard to the backlog, can you give us an idea of what the current rate of backlog is? And could you also maybe provide us with a bit of information on the difference between those who are paying for it privately and the public patients, what the difference in wait times for those is?
Sure. So while the backlog is often quantified in terms of total slides, in reality, which is around 79,000, say close to 80,000, we would always have around 20,000 slides that are working through the system if things were on an even keel. In some ways, the critical determination is the turnaround times for women to get their results, what's called the TAT. We've made significant improvements with two of the laboratories, the Coombe and Quest, and they're now down to 3 weeks and 7 weeks respectively. That can vary week to week a little because
3 for the Coombe and 7 for Quest.
Yeah, and they can vary a little week to week based on either demand or the system is so sensitive at the moment, if there's 1 or 2 staff on leave or whatever, those things can affect it. But we've got additional resources into those laboratories, and we're working on a solution with the third lab, MedLab, which is up at 33 weeks, and clearly that's a major concern, and that has deteriorated. Notwithstanding, and I mentioned this in the opening statement, that the clinical advice on this is that, look, that still presents a low risk. Clearly, from the experience of this crisis, this is very worrying for women. We see it coming through on our information line. I met the staff that manned the information line last Thursday, and we see there's a lot of anxiety, understandably, around it. Our focus now is trying to put in place some of the solutions that we've identified over the last number of months to get capacity. I mentioned in the opening statement we have literally had to trawl the world from Australia to America through Europe to try and find capacity. We also have to take that on in a way, given the experience through Dr. Scali's report, that we go through a full quality assurance process for any laboratory that we connect into the system. We are also developing a public laboratory at the Coombe, and there's a commitment to that, and we've received funding this year to do that. we've set up a couple of project teams, one to build the lab, so there's a construction project involved, and also then to staff it. We have very limited medical manpower in cytopathology in this country. That's one of the issues for us. So we have to grow the medical workforce and we have to grow the screening workforce. Getting screeners is very difficult because when a country moves to HPV primary screening, and you'll see in the UK at the moment, they're under huge pressure with backlogs as well. Part of their reason is as they switch laboratories over and consolidate from the old testing model to the new testing model, the requirement for cytology reduces, so people who've made careers in that are leaving. And that presents challenges. We are trying to pick up some of those people from the UK and come up with all sorts of propositions to get them to come and work here, even temporarily, to help alleviate and to reduce the time. So we are in the middle at the moment of fairly complex negotiations, which clearly I don't want to compromise. Some of those are going on as we speak today and over the last week or two to nail this down. But we are more optimistic than it would have been when we were last with the committee in relation to getting extra capacity on board that will help to address it. In the longer term, Deputy, going back to your question, our aim would be to rebalance between the current model where we have about 9% in the public system, 81% in the private. The commitment to build a lab at the Coombe will help that, but that is going to take time. So in the short term, we have to avail of capacity in other jurisdictions to try and help to get us out of the problem that we're in at the moment, in order to ensure that women get the results.
Okay, but if you pay privately, you can get it turned around in 3 weeks, and if you are a public patient, you can, as you said yourself, wait up to 33 weeks. So that's very, very worrying. You know, that the capacity seems to exist for those that have the money. But with regard to the extensive efforts you're making to source the capacity overseas, and you talked about quality assurance, does that involve on-site visits?
It does. So, for example, in one of the laboratories where we have a number of prospective labs, we have a team assembled. So we've brought in, and Lorraine can maybe speak to this in a moment, in terms of the quality assurance process, which follows on from Dr. Scally's report. We've tried to strengthen the quality assurance, and there's a number of steps that have been taken. And maybe I'll ask Lorraine just to speak to those.
Okay, so since I took up post, I have been looking at the governance arrangements within the service, which includes the quality standards for aspects of the programme. First priority was to look at the laboratory QA standards or quality assurance standards to ensure they were fit for purpose, and we've undertaken a complete review of those. Alongside that, we've planned for, as you call them, on-site visits to laboratories that will be providing this service to Ireland. And the programme...
Sorry to interrupt you. Will those on-site visits take place before or after the contracts are signed? There are on-site visits to start now with the existing laboratories that are working with us. They're starting next week when we will be, a team of us will be visiting some of those laboratories. I'm just talking about the additional capacity, though. So I mean, we can go back over...
Oh, yes, sorry. I misunderstood your
will the contracts be signed first and then the QA happen, as is clearly happening with the on-site visits at the moment, because these people are under contract? So when my question was in reference to your efforts to source additional capacity. And what I'm asking is, and Mr McCallion referred to the ongoing negotiations, will there be an on-site visit before contracts are signed?
My understanding is the contracts have not been signed yet, and the on-site visits are starting on Monday.
So our intention is that the QA visits will be completed before we actually start to move in terms of the final contract, or subject to contract. Contract will be subject to QA. There'll be a number of legal ways we could address that. We obviously want to tie down the capacity, but we will not be tying down the capacity unless the quality assurance is in place.
So the on-site visits, one more question, with regard to the recalls, so we've had the, as is the form with this evolving scandal, the drip feed of information into the media. We now learn that there are samples expiring and that they're going to have to be recalled, and we know that 1,000 women, I think it was, got a letter recently. Are you anticipating that there's going to be more recalls of that nature, or do you have that, are you on top of that situation?
I can maybe address that. I think, Deputy, that was misinformation. So basically, and this is important in terms of, and I know you yourself have said this on several occasions for the public, there is always a percentage of samples that will expire for a variety of reasons, and that we monitor that very closely. There was an issue around, I think, October, November last year that was addressed with the labs, and the rate, if you like, is within the norms that we would always have. I think that was old information that might have been misrepresented over the last number of days. So just in terms of expiration, the change, there's been no change in that sort of normal rate that any screening programme would have around that. So
but given the level of the backlog, the actual numbers, if you're talking about a percentage rate, but the actual numbers are going to be quite high.
It's still a very, very small, it's a minuscule proportion in the scheme of the total numbers going through the programme, and we monitor that.
But can you give me an idea of the number?
I can. Just give me 1 moment. Sorry, Deputy. So if I take it in terms of expired samples and vials, in a typical month it could be about 40 to 50 over a year between expired samples and expired vials. You're looking at around 500 to 600 a year. So it's relatively small numbers in terms of expired samples and vials. And we did have a spike for a period, and that was addressed with the labs.
Okay.
We're now going to move on to Senator Colin Burke. Senator.
Thank you very much, and thank you for your presentations here this morning. First of all, to Dr. Doherty, just to wish you every success in your new role. And can I just ask you, one of the issues that arose here this time last year was how overnight the credibility of the people in charge of cervical check changed overnight. And a lot of it was where it was a misunderstanding in a lot of cases of information that was going out. And I'm just wondering, you know, it's a very serious issue where you're dealing with a screening programme, and it's about making sure that the correct information is going out at all times. Can you see a situation where a controversy could arise again very easily, and how do you intend, I suppose the one issue that arose in relation to cervical check was there wasn't a continuous I suppose information being released by cervical check over the years. It was very much kept very I suppose low-key, and I'm just wondering, is there a plan about making sure that all relevant information is made available to the media on an ongoing basis now that you have taken in charge of this area, and to make sure that you don't have a situation where misinterpretation is given of information as it becomes available?
Okay, thank you very much for your question, Deputy, and I'll answer the issue around communication in the context of public information and professional information. So, as you may be aware, my background is in the NHS, and when I've had to deal with loss of confidence in a service or a crisis in a service, communication is always one of the learning elements we identify that needs to be addressed. So it's fundamentally important that we get that right. Now, as I have only recently joined the service, I haven't been involved in the most recent update of the public information, which is very impressive and which you will see on our website, which is the information for the public and for the patients. And I can ask my colleague Michelle to speak to that in a few minutes. But going forward, communication is fundamentally important to the programme. Everything needs to be open and the professional communication needs to be well informed and well developed with professionals. So there is a programme of work ongoing to enhance the communication arrangements within the service, both for the public, for the patients and for the health professionals involved in the programme. We are working on redeveloping the information for health professionals in the context of the move to HPV primary screening. We are developing new educational resources for health professionals, and we are establishing new lines of communications with our consultant colleagues who I met yesterday to ensure they're kept fully up to date with guidelines and information within the programme. If you like, I can ask my colleague Michelle to speak to the public information and the new information that's been developed for the public.
Yeah, but just can we go back on one issue? What happened here in relation to cervical check? In literally over a 48-hour to 72-hour period, the credibility of the whole cervical check programme changed. What I'm saying is, are you satisfied that we have enough, that the structure that we have now in place would prevent such a situation arising again?
The answer to your question is yes, I am satisfied. I think we've put in place enhanced governance arrangements and enhanced staffing around all aspects of the programme. And I think communication has been a strong focus within the service. Since I've arrived, I've seen that there's a communications working group. Communications work with us on all aspects of our programme. So I'm satisfied that we pay good attention to the communication aspects of our programme, and I'm satisfied that we're working extremely hard to ensure that we never have a crisis of confidence in the service again.
Okay.
Your question. So I suppose just in relation to Dr. Scally's report, so Dr. Scally made a number of recommendations across lots of areas, which we've all covered in different formats, but just in relation to the information that we give to patients. Since Dr. Scally's report was published last year, the HSE has made significant changes in the information that it gives to women and service users of cervical check. The information is unrecognisable, I would say, in comparison to the information we had given people previously. That was done in consultation with patients every step of the way since last September. I think if you look on our website, there's been almost 200,000 visits to the website to the new information since we changed all of that. And this is all on foot of the recommendations from Dr. Scally. All of those recommendations have relevance across information, governance, quality assurance, and so on. So I think there's been a huge body of work that we've already done in relation to the information that we give to the public. As Dr. Doherty also referenced, the information that we share with our clinical colleagues is also something that we've worked really hard to improve as well. So I think there's been lots of learning from the inquiry by Dr. Scally and his report, and all of his recommendations, as you've read in the report, are being fully implemented by the HSE.
Okay.
I just add maybe to Mr. Burke as well, if I could, I still think, that this was a crisis of probably the most significant proportions for a very long time, and I think there is a lot of learning for the system as a whole, and we have tried to look at that in terms of how it might apply to other settings also. There are still significant challenges, I do believe, until we address the backlog. If I'm a woman sitting waiting for a long period of time, communication for me is important to know when am I going to see my results. So we recognise we still have work to do. Just to go back to Senator's Burke, a lot of work has been done. A lot of the ingredients have been put in place. But I wouldn't sit here today and say to you that in terms of if I have someone out there waiting, which is the ultimate measure, that we can give people that level of clarity around results. And part of that is down that we haven't been able to actually nail down the capacity and so on. So people want certainty. There's very specific things they want. So we'd recognise there's a lot have been done to improve that. We still have a long way to go to recover all of that and to get the whole service to a stable footing, because screening is about a process from the GP through the laboratory, through colposcopy, through treatment, the whole flow for the patient through the journey. And the other point I'd make is that personally, I think collectively we would feel we've learned a lot from patients in this. So many of the patient advocates that have stepped up have brought a huge change, and really patients are at the centre of this, and we've seen it in unfortunate circumstances perhaps how it's transpired, but that has made a huge difference. And we've also seen, as we've brought patients into the various aspects of the programme, into the structures, it brings a unique change to the way we approach our work and the way that we link with patients. So I think there's a lot more that can be done in that, both in screening and across the system.
Okay. Could I just cover three things, and rather than going at them individually? The Royal College report, I mean, we're now talking about the various information getting to them. When is that expected to be back from them? The second one is in relation to developing labs in Ireland. At what stage will we arrive at a situation where we could have anything up to 80% of the work in relation to analysis being done in labs in Ireland, as opposed to, my understanding is that it's less than 50% at the moment. How long will it take us to get to even, say, 75, 80% of the work being done in Ireland? And the third issue is in relation to recruitment of lead clinicians in this whole area. As you're aware, there's quite a big challenge in the HSE in relation to recruitment of consultants. There's over 500 consultant vacancies. I presume this is an area that will also be affected, and looking at, and I've raised this issue previously about long-term planning, for instance, looking at how many lead clinicians in this area are going to retire out over the next 5 years, and are we forward planning to make sure that those lead clinicians, that we have replacements for them? Because one of the things that I find frustrating with the HSE is about jobs being advertised after the person has been retired, and then there's the locum filling in for maybe anything up to 2 years before there's a new lead clinician appointed. So I'm just wondering how much forward planning is being done in that area.
Thank you, Deputy. I'll pick up just the first couple and maybe ask Dr. Henry just to comment on the workforce planning from the medical side. Just on the RCOG, you'll appreciate the HSE. The RCOG is an independent review.
Absolutely.
Our role is simply to facilitate it. Now, that still involves a substantial work. We have a large team that are supporting through the consent process, the call centre and so on. My understanding is that their aim is still to finish within the 6-month target. The slides, I think over 60% have now moved to RCOG in the UK and Bristol, and further slides, they're all scheduled to move to completion within a matter of 3 to 4 weeks, and they're in that process. So we have weekly calls with the RCOG, so we're now trying to plan ahead for the end point when they've finished their work, because there will be a disclosure process and a process to feed back the reports to patients at the end, which the HSE will have to support as well, and we've commenced that. In terms of the public lab, so we made a commitment to develop the public lab at the COOM, and we're very grateful to the COOM and their board for working with us on that. The COOM currently undertake about 9% of the programme's work. There is a significant development task in terms of staffing to develop medical consultants who have the specialties that we need. There are 1.5 hold times in the system at the moment, so we need to build resilience into the system around that. And the COOM have been very supportive of the programme and provided a huge advice and support to us in terms of how to deal with a lot of the issues that we face in it. The other part then is the infrastructure. So we have allocated funding, initial allocation to the development of the National Cervical Screening Lab, and we're currently going through the design process. So while I haven't got a detailed plan, Deputy, we are using the sort of fast-track modular build to get there as quickly as we can. And hence, I think, as I said in my opening statement, between the workforce side and the capital side, I would anticipate it'll certainly take us up to 2 years to get there. So the implication of that is that in our HPV primary screening, we will need to run a tender to ensure we get a partner to work with us, and both to maintain the programme as it is today, but also in order to deliver HPV primary screening as quickly as possible. And my colleague Dr. Harty can speak to that if you wish on the HPV
but just
side.
the percentage of the work that will be done in the labs in Ireland?
So we reckon within 2 years you could get that up to about 50% in terms of the work that's needed from the workforce side and the building side and the equipping side and so on. And that's taking a very aggressive approach. This is not just a sort of plug and play, unfortunately, model.
Yeah. Accept that.
It's challenging to get consultants now that might want to work in this area. So we have to look at merging specialties, and we're looking at that with our own medical manpower people in terms of how we could design that. We've been working with the college, the RCPI have been working very closely with us on all of this as well, and there's a huge commitment by everyone to try and improve that. We also need to be conscious that we need those partners to work with us over the next number of years and beyond, and also in most countries the model is also trying to have more than one laboratory so that you have some resilience in the service in the event that you had another crisis of any sort. And to illustrate the point, people may remember the tragic death of a lady in the UK, Jade Goody, which caused a huge spike in people, and the programme ran into all sorts of problems at that time as well, nowhere near the circumstances we're in today. But you need to have that capacity to be able to increase the programme as you need to the resources.
Just for clarification, what percentage of the lab work is being done in Ireland now?
So in the COOM do 9%. MedLab do 45%, or say 10% in the COOM, 45% in both Quest and MedLab. That would be the breakdown at the moment.
Okay.
So maybe I'll ask Mike, do you want to speak to HPV, or would you prefer to talk to... Yeah, Lorraine, maybe you want to touch on that.
Okay, as you know, the strategic intent for the programme is to move towards HPV primary screening, and we have established an active planning process for that. We have an overarching HPV steering group, a HPV project group, and a clinical advisory group. We've also undertaken a programme of visits to other centres who have introduced HPV primary screening to learn from them what are the key things we need to consider within the planning and implementation phases. So there are a number of things, work streams that we've already established around laboratory issues, communication issues for patients and professionals, training and education for professionals, clinical pathways, colposcopy impact assessment, and our IT system. So all of those are factors within the work programme that need to be addressed. What we do know, what is critical to taking this forward is addressing the backlog, so to make sure that we have capacity to take forward this new part of the screening programme, and also to ensure that we have a contract in place with a provider to provide the service. So my colleagues have been working on developing the tender arrangements for a provider for HPV primary screening. So there's a lot of work to be done. But I must stress that we have to have stability within the programme before we can start moving to a completely new mode of screening. I think that's absolutely essential. And we must make sure that those who are going to be called for screening are fully aware of what HPV primary screening means and that they receive all that information before the screening programme starts. And very importantly, we need to make sure that those who will be responsible to deliver the programme, i.e. the smear takers, the GPs and the practice nurses, are fully supported with professional information and training. So as you can see from what I've just described very briefly, is that there's a considerable body of work to be undertaken to reach the end point to where we deliver this programme.
Just on the
just one more question, perhaps, and then.
Yeah, just the medical point, I think, on development of medical manpower and leads.
Yeah, that's the one concern that I have, because there's quite a number of clinicians to retire out over the next 5 years, and I'm a bit concerned about that.
Thank you, Senator. We don't just face problems with recruiting consultants in obstetrics and gynaecology, but right across disciplines, particularly in Model 3 hospitals and mental health, and Model 3 hospitals mostly in unscheduled disciplines. So the only structure we have to address this at the moment, some of this relates clearly to changing conditions for consultants, but also fewer trainees want to work in smaller Model 3 hospitals in single-handed departments or small departments. What most trainees want to do, and we have surveys showing this, is they want to work in larger departments in urban centres where they can do more complex work. So our approach to this, not just within obstetrics and gynaecology and colposcopy, is to look from through a hospital group perspective as how we can create hospital group-wide departments. But it does ask bigger questions of us as to the sustainability of us providing so many unscheduled services in 27 unscheduled care hospitals, and that's some clearly questions we'll have to address as part of manpower planning, because simply these jobs aren't as attractive as they used to be.
But there are quite a number of clinicians to retire out on that area over the next 5 years.
Correct, Senator. There are both here and in other disciplines, so it's not an issue for us confined to colposcopy. We have in some Model 3 hospitals we have over 50% of consultants between 55 and 65 years of age. That's correct.
Okay. Just to give the Deputy Assurance, just the impact assessment process that Dr. Harty referred to earlier on colposcopy is looking at the wider issues, not just the immediate crisis, but also HPV and beyond. So how do we create a sustainable service? That doesn't mean there are magic answers, but at least we look at that and try and plan as best we can around it over the next number of years, which I think is what the Deputy is referring to in terms of colposcopy itself.
Thank you very much. Thank you, sir. Thanks.
Deputy Murphy. Thank you.
Thank you, Chair. I'd like to welcome you all here this morning and to wish you luck, Dr. Doherty, in your new role. I hope it all goes very well for you. Most of what I wanted to ask has been asked already, but some of the answers I'm just not satisfied with, so I am going to go over a bit of old ground. The Minister sat where ye are sitting today and told me a few months ago, when I asked him why he went ahead with the out-of-cycle testing when it was clear that it had been recommended that he doesn't do it, and he looked at me and he said that that recommendation hadn't reached him. Now, with what has come out last night, I think it did reach him, and I know he's not here to answer for himself, but clearly officials in the HSE and the Department of Health were told not to go ahead with it, or it was recommended that they shouldn't go ahead with it. Do you think that that advice reached the Minister or didn't reach the Minister?
And I suppose, Deputy, I think, as I've said earlier, like we can't answer that question for you, in the sense that A, we weren't there at the time, and B, that's something really that the department can probably address in terms of that issue. All we can do, I suppose, is try and explain the context for it at the time, the breakout in terms of the pressure on the programme, the 90,000, how it splits between the out-of-cycle and new women and women re-engaging with the programme. But, you know, we're trying to look at how we solve it, you'll appreciate, going forward. And in terms of the retrospective piece, I don't think we can add any more to that.
Okay, thank you. Do you believe, and I suppose this is for Ms. Tate, that the smears that resulted again from the out-of-cycle testing, do you believe that they're still clogging up the system? And if so, is it having an effect on the implementation of Dr. Scali's recommendations?
I think everything has been done in parallel, Deputy. I think the implementation of Dr. Scali's report covers many areas across the HSE, and clearly the work that's been undertaken to clear the backlog is impacting on us being able to progress some of the recommendations within Dr. Scally's report. But clearly everything is being managed in parallel. So I think there are lots of areas that Dr. Scally looked at and made recommendations on that we've been able to progress, despite there being a backlog with some of the smear tests at the moment. So I think, it's important that, there's lots of moving parts in all of this, and everything is being done in simultaneous as teams of us working on different parts of all of this. So I think there definitely is an impact, but not across the whole of the implementation plan. You'll have seen recently Dr. Scally actually talked about the progress that the HSE has made so far in delivering the implementation plan. So I think for the moment everything is being done in parallel. There's lots of moving parts in this, but I think some of the areas that we want to move towards, particularly in relation to developing the HPV screening programme, obviously the impact of that, as Dr. Doherty has talked about, will be that we need to stabilise the programme and have the backlog reduced significantly. So when we move to that part of Dr. Scally's plan in terms of the future and what screening services will look like in the future, clearly that will be dependent on some of the issues that are currently causing the delays in the system being addressed.
Okay, thank you. And just to tie in with that, can I ask you what is being done to ensure that people continue to have faith in the whole system of screening, and what are you doing to make sure that people continue to be screened, please?
No, I think it's really important that, and Damien has referenced, we have opened up communications with patients on this from the very get-go. For me, as the implementation lead for the Scally report, one of the objectives is that we want to restore the public confidence back into the screening programmes, and particularly into cervical check. And I think, we've made huge efforts in relation to keeping those communications open with the patients, encouraging the public to still attend for their smear tests. This programme has saved lives. This programme will save lives, and it's really important that people continue to have the confidence in the programme and attend for their smear tests when they are called. So, as I said, it's work that we're doing in parallel with everything else that's happening throughout the organisation.
Yeah, I agree with you there. I suppose I never miss an opportunity to advise people just to please, continue with it, because, as you said, it has saved lives.
Deputy, as you say, even some of those people who have been most affected by this crisis have actually become the greatest advocates. We talked about Laura in different contexts earlier, but I think patients are probably the people ultimately. I do think, as I said earlier, we still have a challenge to restore confidence. We do need to address the backlog. If I'm waiting the period that I'm waiting, that is a challenge for us, and we're working to address that. So I think hopefully as we get through that, that will also help. I think it's through some of those actions that confidence will start to restore. But just at the moment, the numbers are staying stable. We haven't seen a decrease. Last year we saw an increase, even from people who re-engaged in the programme, which was a positive thing. So ultimately that's where we want to be. And I also think HPV primary screening will bring another opportunity, again, to hopefully rebuild more confidence. And as Lorraine has said, as long as we get all of those ingredients right, because the professionals are very important as well. We all have great faith. The GP is probably the most trusted health professional that anyone has, and we have a lot of work. There are 4,500 smear takers and GPs who engage with the programme on a daily basis, and their confidence, let's be honest, has also been impacted. So we have to rebuild that, as well as with the women themselves and their families.
Thank you. And just, can I have one more? Yeah, please.
Ms. Murphy.
Thank you, Chair. What I'm very concerned about is, the news that if you pay, you can get your result faster. And I just, as a woman, I am very concerned that if you have enough money to pay for it, you can get your mind put at ease, and if you haven't, you're expected to wait. And I'm just wondering how we can stand over that. I just think it's an awful system.
Well, I suppose the public-private piece is a reality of our healthcare system in terms of how we deal with it as a whole. But in terms of within screening, we are looking at the numbers that are there, and the numbers haven't, in the two labs that undertake a small amount of private work, it is very small. It's not significant in terms of the numbers that are there. Now, having said that, every test at the moment for us, given the search that we've been doing around the world, is critical. So we are continuing to make sure that none of the providers undertake an extra element of that, but that's outside our own contract with those providers. But it is very small in the context of what we want. Our focus with the current providers is really on ensuring they give us the extra capacity that we need to deal with the backlog and to make sure we get the program on a stable footing.
Yeah, I just
and
think
as I said earlier,
very unfair.
we're really trying to focus, and that's significant volume. I mean, there's no point in pretending otherwise. We need significant capacity to address this, and that's what we've been working. And we have, in recent weeks, started to make inroads into that, but that has involved talking to, as I said, countries right throughout Europe, Australia, America, laboratories, public and private, to try and find people that would maybe work with us to help us to get through this. You know.
Thank you. Thank you, Chair.
Thank you, Deputy Murphy. We are now going to invite Deputy Bernard Durkan. Sorry, Deputy Kate O'Connell.
Good morning. Thank you for coming in. And just to add my voice to the tributes to Laura Brennan, I think what was so significant was her age, and that when you have people my age telling a teenager what to do, they mightn't listen, but her age and her youth, which was, I suppose, ultimately the tragedy of it all, had such an impact. And it's not too long ago since a few of us were in here battling to try and get the vaccination rate up no more than yourselves, and we were dealing with terrible abuse on social media, as did Laura Brennan, and it's great to see how she was able to stand up in the face of such abuse and has effectively saved lives and saved, to my mind, the programme, the HPV programme, because we were, let's call a spade, we were heading to under 50%, and therefore it would not have been a viable vaccination programme. So she saved lives, and I think we should all be forever grateful, but I think we should see it as a line in the sand, the 70%, and it would be a disservice to her to let it ever go under 70% again. I'd like to see it up at 95%. Just to follow on from the previous speaker, Deputy Murphy O'Mahony, and about fairness, I just want to address the additional smear issue, out of cycle or additional free smear. My understanding was at the time there was pressure in GP surgeries with women of means turning up asking for an additional smear because they could afford to get it, and the response was to provide a free smear or the option of a free smear. And from the previous meetings here, that it wasn't that you went in with a token and got a free smear. There was a clinical decision at the bedside with the GP. So just for the record this morning, I think it's very important, perhaps whoever, maybe Lorraine Harty, you might outline that it was a clinical decision at the bedside, that it wasn't a token for a free smear. Just because I think it's important to point out that everyone wasn't given one.
Okay. Well, thank you for your question, Deputy. As you're aware, I wasn't involved with the service at that time. I'm not aware of, what information GPs were sharing at that time in relation to the demand for services. So the decision to undertake a cervical smear is between the GP or the other doctor and their patient. So it is a decision that's taken in a clinical consultation context, and it's a clinical decision. What informs that decision is really between the doctor and the patient, and I can't comment on what individual doctors would discuss with their patients. But when an intervention like that, as I've said, is offered, it is the decision between the GP and the patient as to whether or not that's appropriate for that patient.
In terms of the backlog, if I have my figures right, 280,000 women in 2017, going up to 370,000, which is an increase of 90,000. But the backlog is essentially the guts of 80,000, 79,500. So is it true to say that really the only extra capacity is 10,500 in the system? Like we still have a massive, there's a backlog of 79 from the opening statement, 79,500. So I'm reading that as all you've found is 10,500 extra spots. Yeah,
what happens, Deputy, is I suppose you get peaks and troughs in this. So unfortunately, it's not as, the numbers get more complex in terms of how we've gained it.
These numbers are true.
No, I'm not doubting the numbers, sorry.
They're your numbers from your opening statement.
No, I wouldn't want to, would I? Just all I'm explaining, I guess, is there's been peaks where there's been huge gaps in capacity, and then we've acquired capacity, and then that's grown, and then some of that capacity is temporary, so we have it for a period. One of the key things in this is to get the capacity in quickly. It needs to come through the existing providers. So the process of connecting a new laboratory involves probably a 4 to 5 month process. It's not a simple process to just plug and play a lab in, apart from the issues raised earlier from the quality side. So in terms of plug and play, in Dr. Scali's report, we discovered that some of the labs in the US were not ISO accredited. They were accredited to the American College. Are you still using labs that haven't got the proper, or the accreditation that was in the contract? Yeah. So Dr. Scally ultimately was satisfied that we could continue to work with both Quest and MedLab and the COOM.
My understanding is that he wanted clarification where the equal, and I still haven't clarification. I don't think this committee has received clarification that the standard, the self-granted American standard, is the same as what we requested in the contracts.
Just 2 points on it, Deputy. So one is that Dr. Scally was clear from his first report that we could continue to renew the contracts. He had no performance issues with Quest and MedLab. On the point then in relation to the accreditation, that's subject to his second report, which is still ongoing. I've maintained close contact with Dr. Scally to ensure that any additional work or capacity we get from the existing laboratories, that he's satisfied that there's nothing that he's uncovering through his process that would lead to any concern.
So he's happy enough to renew the contracts, but perhaps not to create new contracts if the accreditation wasn't equal.
So I met with him as recently as last week, and while his report is still ongoing, he hasn't completed it yet, his second report on the laboratories. He did complete his progress report on the implementation of his report as a whole. Currently, he's still satisfied that we can continue to negotiate with the laboratories to ensure we get additional capacity.
Laboratories with what accreditation?
With the existing providers. Yeah,
with existing providers?
Yeah. So
with existing accreditation?
Exactly, yeah.
Just to roll back a bit, of the extra people into the system, the plus 90,000, what proportion, this is for smears, that entered the system between 2017 and 18, what proportion of that can be attributed to women engaging with the system for the first time? Is it a tenth, is it a third, is it 50%?
Around a third is our estimate of that, yeah, it's slightly below it, but around a third is new. I think it's about 26,000, 27,000 is the estimate, yeah.
And just in terms of transition to HPV testing, I think was it 2 years somebody said to get it up and running? Is that from now or from then?
No, I'll ask Dr. Harty speak to that in a moment. I think one of the things, the HPV date is obviously something we all want to get to as quickly as possible. And the critical path for that is really why we've been holding off on the date. So I'll ask Dr. Harty maybe
because
to speak
we did hear from, I can't remember, Denton, was it Dr. Denton from Scotland was in with Dr. Scally here? Was it Denton? That with the, I don't want to misquote her, but the gist of it was it could be done within a year. And it's about 6 months since she was in this committee.
Dr. Denton's comment, just to clarify, I think it was in relation to the time from start to finish. This is something that's obviously been worked on, but I'll ask our circumstances. So we've met a lot of the different countries. Every country's circumstances are different. And maybe ask
and in terms of meeting other countries, because you talked about trawling the world, does that mean you're all physically going places?
Thankfully for conference calls and the like, we have had people go to some places to speak to people, to Holland, to France, to the UK, to Northern Ireland.
Australia?
Not to Australia, Deputy, no. We did a conference call with them and we've worked with them in terms of possibilities there.
Because in terms of gold standard, they have an aim to eradicate cervical cancer in 10 years.
They're more advanced in many ways. They've had screening for a lot longer than we have in many other countries. So we've worked closely with Australia as well. I guess I should say there's two objectives. One is to try and find capacity to deal with the backlog. The second objective, though, is also to try and identify laboratories that might work with us in HPV primary screening. There are big challenges when a company looks into Ireland at the moment, and we have to try and make sure that we I suppose, can attract people to work with us. That is a risk we're having to manage around this. This isn't something that we can, in a normal tendering environment around HPV primary screening. But I might ask Dr. Harty just to speak to the timeline question for you, Deputy.
Okay, thank you for your question. And as I've outlined earlier in one of my previous answers, there are a number of steps that we have to go through before we can move to HPV primary screening. We have taken evidence from a number of countries in terms of how they've led the development of their programme. And while we haven't visited Australia, we have been in contact with colleagues there, and we've done a detailed review of some of the NHS programmes, and in particular the Scottish programme. So if you look at how other people have taken this forward, a variety of approaches have been adopted. In some regions in Australia and in New Zealand, they stopped programmes for a while or suspended programmes for a while to allow to introduce programmes, the new programme. The laboratory issues are fundamentally important in terms of having a recognised service provider and then plugging that laboratory into our existing call and recall systems and how we generate results. So all of that takes quite a bit of time. The planning and implementation phases take quite a bit of time to put together to ensure they're done in a safe way and an evidence-driven way, and to achieve a quality service at the end of that process. So it's not a thing to be rushed in a period of a couple of months. And I think, getting a laboratory provider to contract with us is unlikely before, at least later on this year. So we can't give you a definitive timescale for when this service will be introduced, but you must recognise that we have a very robust work programme going on to move us towards that point.
And in terms of your comment on suspension of the programme in other jurisdictions, to bring in a new sort of a line in the sand, I assume, is sort of moving from one to another. I'd imagine in terms of the Irish situation that because of the complexities of the last 2 years, we wouldn't want to see any suspension of a programme. We've had enough difficulty, I'd imagine. I'm just making sure that that's not selling a suspension of the cervical programme.
No, I mean, I think if we go back to earlier conversations in this room about rebuilding confidence in the programme, we want women to know that the screening service is available, that they can access the screening programme, and they will be called to screening when it's their turn to be screened. I think stopping the programme would be a very difficult decision, and not one we would want to take if we were to restore confidence in this programme for women.
Thank you.
The Deputy, just to give assurance that our sole focus, and we have made movement with 2 of the laboratories in terms of their turnaround times, is to address the 3rd lab so that we can actually get the programme back to an even keel, and then that allows us to move on with HPV primary screening. We would love to see that go in this year, but whether we can do that will be contingent on the tender process, and that's really going to be the critical path, is identifying a partner that will work with us to get this in as fast a time as possible. And again, echoing Lorraine's point, in a structured, sensible, safe way as well. But that's our objective.
Thank you.
Thank you, Mr. McCallion, and thank you, Deputy O'Connell. Now, Deputy Bernard Durkan.
Thank you, Mr. Chairman. My apologies for being late this morning. We had a constituency engagement. And can I just ask a follow-up, Deputy Murphy O'Mahony's question? Who advised the Minister not to go ahead with the review of a programme? Where did that advice come from?
Well, I think the context for the discussion this morning came from a document from Dr. Gráinne Flannelly overnight, which we only saw overnight, and I'm not aware of what happened at the time, Deputy. So I just need to be clear on that in terms of. Personally wasn't around at that stage, but also I think in terms of how that was engaged. So I can't give you any more information than that in terms of the historical context of it. As I said earlier, our focus is trying to resolve this going forward and ensure we deal with the backlog.
But if somebody advises the Minister, senior officials or a body advises the Minister not to proceed in a particular fashion, there has to be some reason, because presumably the Minister erred on the side of safety. To reassure the public insofar as can be done, which is a big issue insofar as we are concerned as well, because the public ask us questions from our perspective in this committee, and they're not always kindly respond if we can't give adequate answers, and it doesn't really tell with them if we say, well, we haven't been able to get a straight answer to that question. So the question still remains, who gave the advice? On what basis was it given? We need to know that clearly. We need to be absolutely clear about that, because our job also, as members, as public representatives, and as members of the public, is to try to convey to the public to some degree that we know why this happened. We need to know why it happened.
Deputy, just earlier we were asked this, more or less similar questions, and we became aware, as I said last night, of Dr. Flannelly's written statement and advice that she gave, and I'm taking that at face value. But to my knowledge, no other advice was sought or given from the HSE apart from the advice that Dr. Flannelly states she gave last night. But I did explain when I was talking earlier in this matter that it's important to remember, while we're focusing on the backlog quite correctly now, at that time there was a huge amount of public anxiety, and this was and it's quite easy to forget that. Women were very concerned. There was a great deal of misinformation. There was a great deal of mischaracterisation of this crisis, and there was a danger of collapse in confidence in the screening programme. And bearing in mind, this screening programme has saved lives over the years. So at the time, and it's not for me to explain how the decision was made, because, as I say, I didn't know, but I remember very well the concern that our phone lines were completely oversubscribed in terms of people trying to phone in, seeking advice and seeking reassurance, and general practitioners right across the country were facing women who were similarly very, very concerned. And this concern was reflected in the media, at political level, including committees here in the PAC, where we faced questions about crisis and confidence. So it was in that context.
That's not for the business of the PAC now. That's the business of this committee.
I understand. What I'm doing,
the PAC is a different function altogether. It's reviewing expenditure, not public policy. It's not their business at all. So I want to reiterate that, Mr. Chairman.
Deputy, I merely reflecting the fact that there was concern expressed at different agencies, different subcommittees in the media, and this reflected a huge public concern of the programme, a huge amount of misinformation and misunderstanding over what the crisis meant. And it was in that context that my understanding is a decision was made that there were measures had to be taken to alleviate public concern.
Maybe just to illustrate that.
A week ago or so, we read in the papers, and I'm not naming the messenger now, this is the fact that 2,000 women still to be tested on a waiting list, or 2,500 women as the case may be. Between the crisis first bursting on the scene and this week, how many of those women in that particular review have that 2,500 or whatever? How many have been tested in the meantime? What happened in the meantime? See, what I'm worried about here, Chairman, is this: is that we go from week to week, and we have another announcement that something else has arisen, or there's some pending problem, and that erodes public confidence in the system. And we need to get to the bottom of that. You know, is it capacity? Is it a capacity problem? To what extent is that a capacity problem? Would we be better off investing in national capacity rather than subcontracting out? Because the investing in national capacity is a once-off capital expenditure. The other one is it repeats itself every day, and every person who's tested, it's a repeat. So has any analysis been done on a cost-benefit basis of that?
So maybe just to address that for the Deputy. So the programme, I think I mentioned earlier, 9% of it is in the public system with the CUM, and our aim is to build that up in order to give greater resilience within the programme. Funding has been allocated on the capital programme to advance the development of a national cervical screening laboratory at the CUM. We have a steering group in place with the CUM, a joint group, and we have a project team, and we're now working on the designs for that. We're also working on it on the basis of a fast-track modular build to try and get it in place as quickly as possible. But equally critical, Deputy, and I would have mentioned earlier, is the need to develop the workforce. So we have a very small workforce for cervical screening, cytology, cytopathology here in Ireland.
How short of what's required are we?
It's significant, and the challenge is really more in terms of it's a very
20%, 30%?
Well, if I give to illustrate the point on the medical side, so there's sort of a number of roles. There's the logistics of actually being able to manage all of the smears. That's relatively easy to develop. But on the medical side, we would have around 1.5 consultants in the public system. We would certainly need a number of other consultants, but I think we have to look at a model that will allow those consultants to operate in other aspects of pathology as well. You are unlikely to attract people into a role with just that specialty on its own. So we're looking at how we develop that. And the other challenge, which I mentioned earlier, was that in relation to screeners themselves, because cytology is becoming a much reduced profession. So in other words, in the current model, it will reduce the requirement for cyto screeners by about 80%. So in the UK, for example, at the moment, they have very significant backlogs emerging in some of their trusts, where screeners, because of the difficulties in terms of their future career prospects, are leaving, and where laboratories are being closed. Now, we're actually trying to capture some of that if we can, so that we can help inject here in Ireland, even in the short term, to help us with our current problems. Are we
capturing it on the basis of a better system, or are we capturing the fall-off from their system and applying it here?
No, I think there's two things, Deputy. One is we're trying to capture some resource over the next period, both laboratories and individuals who are qualified to work in laboratories, so that we can address the backlog. That's crucial, because our current pressure is women in some cases are waiting excessive periods, and that's one of the core issues we want to tackle. We have made some inroads in two of the laboratories. The times have reduced in the CUM and with Quest, and we have challenges, and we're working with our other partner to address those. And we actually have found some solutions, but we are trying to work those through at the moment over the coming weeks.
From an absolute health and safety point of view, what's an excessive waiting period? return.
So the clinical advice we have is the periods we have to present a very low risk to women, but what we're conscious of, that is fine, but that, on the other hand, if you're the woman that's waiting for results, that is little comfort to me if I'm sitting at home.
Correct.
So our focus is still trying to address that. Dr. Henry or Dr. Doherty may want to add to that.
Definitely, absolutely. The main risk, as I would see it clinically, is the risk of anxiety in waiting. Cervical cancer happens to be a very slow-growing and takes 10 to 15 years in many cases to develop. So, as my colleague Dr. McKenna gave evidence at another hearing, he described it as an exceedingly low chance, although not negligible, that harm would result as a consequence of the delay, and that the intervention would have changed. But that's not to take away from the distress and anxiety that the delays would cause for women.
What success are you having in terms of, as the weeks go by, of restoring public confidence in the system in actual terms by way of overhauling the numbers? I know you have the long-term plan, but the long-term plan could take a year, could take 2 years, could take 3 years. 3 years is a long time.
So maybe a couple of points, Deputy. One of the labs is now back to the turnaround times that we would pre the crisis. The other is making significant inroads, and we're working with the third laboratory, and we have identified capacity with that third laboratory, which we're currently trying to secure contractually and going through the relevant quality assurance steps in order to bring it on board. So a lot of work is going on to try and bring those times down. And to ensure, I suppose, that because ultimately confidence will be restored for women who are waiting when they get their results. That's one aspect of the restoration of confidence. There's a whole range of other factors that maybe Dr. Doherty might speak to, again, in terms of restoring confidence generally in the programme.
Thanks for your question. In terms of confidence in the programme, the clear strategy we've adopted is communicating in an enhanced way with patients. So earlier in this session we heard about the active engagement with patients who've been affected by this programme and women who would be involved with the programme. We've also completely overhauled all the information that's provided to the public and to women in terms of the programme. My colleague Michelle Tate has described some of that earlier. So if you look on the website of Cervical Check, you'll see a new website and new information for health professionals for patients. And the information that is being sent to patients, to women in the screening programme, has been enhanced and improved greatly to support women in the screening programme. So all of that, we're hoping, will start to rebuild confidence in understanding the screening programme and that the screening programme is still there to provide a service for women. And ultimately, we are working to address the capacity issues around the laboratory and move towards HPV primary screening, all of which will be further confidence building measures for the programme.
Last question, Chairman.
One last question.
You'd be glad to hear that. This is an issue I've raised on numerous occasions in the past. We seem to be bedeviled by waiting lists in this country, or almost everything. It's a waiting list for everything at the present time, and it shouldn't be that. My question is this: as the new applicants are coming on stream, some are more urgent than others, obviously. Do they go onto a waiting list? Is the waiting list being eroded from two sides, in other words? Can you attack that waiting list from two sides? The new applicants for screening, tests and so on and so forth, and for testing of slides, etc. Are they, do they go on to the tail end of the waiting list that are already there? Because if that's the way we erode waiting lists, it'll never happen. Because you'll have a 10-year waiting list before we know where we are. And I don't want to go, we've talked about this before, Chairman, in numerous public bodies, there's this same tendency for a waiting list. And it's a cushion. It doesn't do anything about health and safety. It doesn't restore confidence in anybody. It doesn't restore confidence in the system. And it's not good for the morale of the people who are working in the system, because they are also bedeviled by the constant pressure coming from people who legitimately criticise the existence of the waiting list. So the question is simply this: are we controlling that waiting list? Is it being eroded from two sides, those already on and those coming on, rather than extend the list and say, you know, we're up to speed?
Well, I would say that screening is probably slightly different in that you're screening largely a well population. There are a cohort of women that are identified who have earlier recalls in terms of the programme. And for example, also people who are referred to colposcopy might have a priority. But screening is different, say, for example, to being on a waiting list for an acute hospital orthopaedic outpatient appointment. I might ask Dr. Harty just to comment further on that.
Okay, if we can just clarify, I assume the waiting list you're talking about is the waiting time to get results. Okay, so in terms of the screening programme overall, all women have equitable access to the screening programme. They will be called in turn when it's their turn to be screened. That has not changed. What we have in one particular laboratory is a backlog of smears waiting to be read. And if you will remember from changes made to the screening programme some years ago, we introduced what we call HPV reflex testing. So some smears were tested with a HPV test. We're also aware from previous experience in the system that HPV testing can expire, so we have to make sure that that doesn't happen. So within the backlog, we are prioritising the smears that are in danger of going out of date and applying the HPV test to them in an effort to manage risk, because as you quite rightly point out, there is a waiting time and the risk is that these smears will be out of date and then can't be read. So where a woman is HPV positive, i.e. at higher risk, they immediately are prioritised for their cytology test, and that is already in place in terms of managing risk. We've also prioritised the women who are having interventions at colposcopy because they are also deemed to be at higher risk. So we have adopted a risk-based approach to managing that backlog. But of course, we are as anxious as you all are to find a solution to that backlog and get a provider and staff in place who can deliver the results in a more timely way. And efforts continue to try and achieve that.
Sure. Can I just ask a question on from that? It's very brief. If somebody just turns up in their mid-20s with symptoms, bleeding, perhaps a family history, all the things leading up to it, are they prioritised? So obviously the colposcopy people, as you've mentioned, Deputy Durkan, people with HPV positive, but in terms of your standard woman turning up with symptoms, do they, and I turn up with them, well I'm not really standard, I'm getting on, but a woman of 30 we'll say, with no symptoms and a woman of 30 with symptoms, does the woman with the symptoms jump the list, or is she prioritised?
Okay, so a woman with symptoms does not have to wait to be called for screening before she can address that issue. If a woman with symptoms of like what you described presents at a GP surgery, it's not appropriate to take her smear and just send that into the screening programme. That patient requires a referral to a gynaecology clinic for urgent clinical assessment. So they are prioritised in terms of addressing with their symptomatic condition.
So sort of leapfrog the cervical and go to the clinical setting?
They wouldn't have a smear taken at that time. They would be referred directly to gynaecology for the gynaecologist to assess them and see what the most appropriate management
and what sort of
is.
time for that sort of person, your 30-year-old symptomatic woman?
Well, there's a process for prioritising those referrals in terms of what we call on the referral forms. So where a GP indicates that there is a suspicion that this patient has a problem with their cervix, they can write this on the form, they tick a particular box on the form, and patients are prioritised to be seen more rapidly in gynae clinics.
Like what sort of time?
How long will
2 weeks, a month, 6 months?
I don't have that information because they're not part of the screening programme, so we don't deal with those within the screening programme.
Yeah, the danger, Chairman, there, I don't want to be interrupted, I'm sorry about this. The danger there is that referring is being referred on. For how long? That's a crucial question.
Thank you, Deputy.
We don't know the answer. Yeah?
Deputy, maybe I could answer your question. Your question absolutely highlights the difference, and this is a very important communication message for us, and I know you and others have been to the forefront of this too, in highlighting the difference between a screening programme and a diagnostic programme. Screening is for population, for healthy people that you're getting in to get them, to persuading them to undergo a test that might pick up something. When somebody has symptoms, the screening it isn't relevant to the screening programme. It's now with the 3 cancer screening programmes, namely breast, bowel, and cervical. For all 3 people in all those 3 domains, people who develop symptoms, be the rectal bleeding or be the vaginal bleeding, or in the case of the other cancer, it's direct they enter a clinical pathway that brings them directly to urgent referral to the relevant clinician and bypasses anything to do with screening. It would be a distraction from that.
Thank you very much, Dr. Henry. Yeah. Before I bring in our non-members, first of which would be Breed Smith, can I just say the issues that arose last April were in relation to non-disclosure, in particular in relation to non-disclosure of a look-back audit on women who had been already diagnosed with cancer and now their smear was being reviewed. So that was the issue at the time. The main, and it still is an issue which is being addressed. The issue at the moment is the backlog in relation to smears. And I think it's important to say that about 65,000 women have been identified through the screening programme to have varying grades of abnormality, which have been treated very successfully by the programme and are walking around today oblivious, almost oblivious to the fact that they had a brush with cancer and they were treated in a precancerous stage. So it's very important to say that 65,000 women benefited substantially from the programme. A small number of women did not, and as you've just outlined, a screening programme is not a diagnostic programme, and no screening programme will identify every single cancer. So in population health, the population benefits, but the individual may not benefit. But the majority of individuals do. So it's important to say that. But in relation to the topic that the topics that we're discussing today, in relation to the backlog, and also in relation to moving to HPV testing, which, from what I gathered this morning, are interlinked. And until we clear the backlog, we can't really move, or as you say, stabilise the situation. We can't really move on to HPV testing, which would be a more accurate means of testing. It brings its own challenges and changes in referral pathways, but nevertheless, it's a goal we're trying to reach. So in relation to stabilising the situation, is there a possibility that you do not suspend the cervical screening programme, but you suspend the routine screening for a number of months? So those who are in colposcopy obviously will continue to be screened as per the protocol. Those who are being brought back for early smears because of previous smears can continue to have those smears done. But those people who are on the normal recall system of every 3 years or every 5 years, which is the majority of the people who are coming through the programme at the moment, if that was suspended for a number of months to allow the backlog to be cleared, would that not be a more rapid solution to stabilising the situation and allowing you to move on to HPV testing than trawling the world for extra laboratory services which don't seem to be available, or developing capacity in the Coombe, which is going to take at least 2 years because you're going to actually have to build a structure and hire staff. So by suspending the routine smears for a number of months, could that not rapidly stabilise the situation to allow you to move on to HPV testing?
So we've evaluated that option as well as part of the whole option appraisal on an ongoing basis. So it isn't a case that it's a point in time, I guess, Chair, in terms of looking at the decision making around it. At the moment, we have secured it. So we have 2 labs now who are turning around the results in much lower timeframes, within 3 and 7 to 8 weeks respectively. We have 1 laboratory we're working with to get their times down. They've identified capacity. We're scheduling in to visit that capacity. And we are hopeful at the moment that that would help to address the problem. When you look at the problem of changing the cycle from 3 and 5 years and moving people out, it would involve more than a number of months. You'd have to move it out a significant period in order to address the backlog and the throughput. And you would also still have to address new women coming into the programme because they're a high risk in terms of they've never been screened before. The other challenge you would face, then you would move some of the issue forward into your HPV project because they would have to be called in the following year on an earlier basis on top of the people who would be scheduled anyway, say in 2020. So I'm not dismissing that as an option, but at the moment when we evaluated the options, the preference was to try and secure that capacity. At the moment we have capacity on the table and our focus now is to try and see can we get that into the system, and if we can do that, that will help to alleviate it in a reasonable period of time. I don't want to go into the time today because of the fact that we're in the middle of negotiations with the number of the providers around this. So it is an option that's been considered, and we've set out and mapped it out in detail as we've mapped out all the other options. And I think, as Dr. Doherty said earlier, some programmes did that as a sort of sensible entry into HPV to give the programme a bit of space in order to move in a structured way. I don't know if Dr. Doherty wants to add to that.
No, and just to say, I don't think we would be taking a decision to stop new entrants to the screening programme. I think it's important that women who I would call are screening naive, who've never been screened before and who are eligible for screening, can access a test, because we don't know exactly what their status is. And once they're in the programme, then we have a better idea of how they are. I think, as my colleague Ms McCannon has said, we need to really look at how we're going to address the backlog and capacity issues before we could ever consider taking decisions like we've just described.
So really there is no timeline then for moving to HPV testing, because you can't do that until you've stabilised the existing system. So it could be a number of years before we move to HPV testing.
No, I think what I've described is a programme of work that we're undertaking to get us to the point where we could introduce HPV screening, which includes securing a provider for the service. Preferably, we will have addressed the backlog to introduce some stability to the system. But as I said earlier, we can't give you a fixed timeline or a fixed date for when the HPV primary screening will start. But we anticipate that we would certainly be looking at no longer than early next year to introduce this programme. But we have to make sure that the steps we take are evidence-driven and are safe. There's no point being bounced into rapidly introducing a test without all the other structures that need to be in place around it to ensure the system is safe.
Just to reassure the Deputy on the HPV screening, the critical part is the provision of a provider. At the moment we're at 9% in the CUM. That cannot change overnight, as you've described. So we have to secure a provider from our tender, and that is the critical path. And as Dr. Harty has said, our plan is aiming to get that in this year. Whether we can do it this year or early next year, that would be the target. But for us to be trying to set out dates at the moment, and given the history of this with dates, we need to be sure of our ground before we go and publish a date, and we can only be in that position when we have gone to the next stage of the tender and we're sure we have a provider that we can work with. And just to illustrate the point, if it's a new provider, there could be quite a lag time for their IT systems to interconnect. So the programme is designed totally around technology, and some providers may be able to connect very quickly, some may have an extensive period to connect. So we won't know that until we secure a provider. And as I said earlier, securing a provider in this context is quite challenging for a variety of reasons, and it is a very small market of providers that provide this type of capacity into Europe. So,
and just one other issue, what's happening at the moment and the pressure that frontline staff are under, not only GPs but also staff who are manning the phone lines, they are under extreme pressure in relation to the phone calls that they're receiving from women out of complete frustration with not getting their test. That the pressure that frontline staff on the phones are under is almost unbearable, and there is a difficulty in relation to the stress that they are under and maintaining those staff. Yeah. So it's not as if you can. There is an urgency in even at that issue where people are trying to impart factual information to women who are very worried and frustrated. And it is taking a toll on frontline staff.
And Deputy, I met some of the staff myself last week, and I'm aware of some of the concerns that people have. We're trying to address that in terms of providing more supports from a HR perspective, but also trying to get more regular bulletins out to smear takers and to GPs, because ultimately they're probably best placed to try and give some level of reassurance to women. It is very difficult though when, I guess, if you're ringing in, what you want to know is when is my test going to be back, and given an explanation of progress we're making or things we're trying to do, while helpful, ultimately doesn't answer the person's question, and that's the challenge for the person on the line. So I suppose we're trying to improve that communication, notwithstanding that difficulty, but ultimately putting most of our efforts into trying to get this capacity into place that we can give people a timeline, so at least they can be assured that timeline is there. The other steps that I mentioned at the last committee that we've taken is where, because of the risk of expiration of the for HPV testing, we undertake those tests now, so that also has the added benefit of pulling out those people who are HPV positive and hence moving them through the system quicker. So there's an element of triage in that, and that's something that we're looking at in terms of the entire backlog, that we would try and move that forward using HPV testing first, which would prioritise those people then that are greatest risk, and hence moving them into the system quicker. That's part of the overall plan that we have around the backlog.
Thank you very much, Mr McCallion. So now I'm going to bring in Deputy Bree Smith, and we're going to give 5 minutes to each of our non-members. So if you can be concise in your questions. Thank you.
I have a good few questions, so I'll ask them quite quickly, and I'll ask them in a row, if that's all right. The first thing, I want to thank you for your submission, but I also want to thank Professor Donnelly for hers. It's a very informative submission just on how the whole system works. It's very well thought out and delivered, but on the page where she talks about the 28th of April last year, I think this is a really important piece, because her advice, I'll just read out headlines of her advice, to the department not to proceed with offering a second test, where that laboratories would not have sufficient capacity, open access for repeat testing would be difficult to plan and deliver, colposcopy services would not have sufficient capacity, and it would fundamentally undermine the screening programme. And all of that is very prophetic, because that's exactly what has happened when we've got 80,000 tests in backlog with a 33-week waiting period. And the task to you guys is absolutely enormous. I just want to ask you, was Dr Flannelly a big loss to you? It seems to me that she must have been a huge loss to the service, given the struggle that you have to recruit experts in this field. I also want to ask you, do you think that her advice to the department has resulted, or will result, when this becomes more and more exposed, in a loss of confidence in the department, whomever is responsible, whether it's the CMO and or the Minister himself, for rejecting that advice and putting us into the position we're in now? The other thing I want to ask you about is the record you have of sourcing labs to help you get through this mess. Have you looked to Northern Ireland? They have 4 labs, and I believe they have capacity, and maybe you could address what the result is in Northern Ireland. And you mention all the time challenges with your other partner, having said that you've made progress with Coombe and Quest. I'm assuming that's MedLab. Could you spell out a little bit for us, even I don't want to take up your whole day, but what those challenges may be, the headline issues around those challenges? In your submission under supports to women and their families, you say in the provision of access to their records, you support them in the provision of access to their records and ensuring that their slides, where they're required for legal review, that they can get them. So there's 118 of the 125 slides that have been requested have been dealt with an average waiting time of 27.5 days. This is under the headline of support for families. So there's 7 still in progress. Are there legal proceedings pending in those 7 cases? And is there one particular lab involved, or are there multiple labs involved? Can you answer me that? And under the independent review, you say in recent weeks the labs have commenced the transfer of slides. So I'm quite passionate about this, because last June we were told that the Royal College of Gynaecologists estimated it would take 6 months to conclude, and I understood it meant to conclude their examination on the independent review. But now it looks like that you're being told that the review it'll take time to review the transfer of slides. So has the Royal College of Gynaecologists review taken all this period just to get the slides transferred to them, or is the review due to be completed? And did at any stage the 221 group ask to be removed from that review and dealt with separately, and why would they have done so? And very lastly, information in relation to requests that I have repeatedly made for where what labs the false negatives came from. So I was told repeatedly in PQs and at meetings like this by the Minister and his department that would be dealt with under this RCOG review, that was how it was going to be dealt with, and until that review is conducted, I can't have that information. In a separate PQ, I was told that an expert was being appointed to look at that and to get me that information. All this time later, the information is still not forthcoming. And I want to conclude my query by saying this, that this goes back 10 years ago, the decision to outsource the service was a mortal sin because it has led to the deaths of women. It has led to the mess that we're in with cervical check. And that is what I am trying to get somebody to say, to admit. What scares me now is that the only step forward that we seem to be making in HPV testing is to again outsource. And this, I think, is really, really worrying, that the outsourcing of women's health is continuing, the plans to continue to outsource it, when we know that 10 years ago the decision to outsource has led to a complete mess. I'm delighted to hear you're reinventing the CUM as a public clinical service. I think that's absolutely the way to go, because I think at the time university courses, etc., were shut down because of the decision to outsource, and we lost the capacity to do our own screening in terms of clinical experts that can examine these things. And I'm delighted to hear that they be reinstated.
Thank you, Deputy.
But would you agree with me that outsourcing has been a disaster? Are you concerned that we are now being forced to outsource the HPV test?
Thank you, Deputy. You got all your questions in there. So if you, Mr McCallum, if you could
with my colleagues we'll try and address them. So maybe I'll just take one or two of the ones first that can answer quickest. So in terms of the RCOG will produce the overall report in relation to the laboratories, not just in terms of the 221 women that were initially affected and their families, but also in terms of all of the cervical cases of people who consented, of which there's over 1,000. On the report that the Deputy refers to then, we have completed a report which is simply to give a profile of the laboratories with an explanation, where we got someone from out of state to do that. We're meeting with the patients because it's about the 221, so we've always said the first group we will meet to go through any of that information is with the patients, and we're meeting them in the next couple of weeks, and once they're happy with it we'll release the report, Deputy. So that bit of work is done, but as I say, the patient representatives are our first port of call on that. In terms of the ORCOG review and the 221 group, I'm not aware of a request to be removed. I'm not saying that didn't come, it may well have. The RCOG is an independent process. Our role is really just to try and support it. Now, we have a very significant team working on it because we had to manage the consent process, the information line, and a whole range of areas. But the RCOG is an independent review, and we have a weekly call with them. There are a number of people who've consented within the 221. I'm aware of that. I couldn't give you the exact numbers, but there certainly are people who've consented to participate in the review. There were around 1,800 people, I don't have the exact figures here today, but who had invasive cervical cancer, and of those, about over 1,000 have consented to participate in the review. And those slides are with the RCOG and going to the RCOG, where there's about 1,000 slides gone, and I think in total, I haven't the number of women, but there are more slides obviously than women, and there's about 600 scheduled to go over the next 3 to 4 weeks, which will complete the slide transfer.
But that's not the review. That's not the
No,
completion
so
of the review. It's just the slides going.
Yeah, they have started that process. So once we started sending slides, essentially they've been starting their process of reviewing those slides, and they're also reviewing the colposcopy records and the cancer records. So it's a very comprehensive review.
And do you have a date of when you expect it to be completed?
Well, it's the RCOG themselves that would indicate the date, but the indications I have, and it's just the indications from them, a period of around 6 months. That's the indications. But that would be for the RCOG to confirm the date, and that we're just there to support them.
But with all due respect to you and the RCOG, we were told that last June, 6 months.
I can only say what the RCOG, you know, the information, that's their expectation around it is that sort of period. In terms of sourcing labs, on the third lab, we have identified some capacity through that, and we've been working with them over the last number of weeks to try and go through all of the capacity elements, the operational elements and the legal elements of that. We're at a very critical stage over these couple of weeks, so I'm just being cautious in terms of what we say, but we have identified capacity that will help. We have, as I said earlier, 2 of the labs have made significant improvements, and they have identified further capacity as well. We will, as I mentioned earlier to Deputy O'Reilly, been doing quality assurance visits. There's a new pre-inspection process that Dr. Harty referred to earlier that the laboratory must go through as part of the quality assurance, and there will be on-site visits against the quality assurance standard, an updated quality assurance standard, and those are being scheduled rapidly in order to ensure that we get to a point where we can secure that capacity. It is a real challenge, I'm not underestimating it globally, to try and find laboratories where people are moving to HPV. To get cytology is really difficult, and that's the other reason we want to move to HPV as quickly as possible. In terms of the outsourcing, I mean, what I would say there is we have recognised that we need to invest in the public system, and we're doing that through the CUM. It is going to take a bit of time. It isn't just the construction. That's an important element, and designs have been pulled together, and that's been fast-tracked as best we can. and we've had good support from our own estates people in doing that. But it's also ensuring that we develop the medical manpower, and that's quite complex because, as I said, it's such a highly specialised area. There never were many of these people in the country, and we've activated and talked to some people who've been involved in the specialty before about trying to re-engage them. And we're looking at trying to grow and develop the consultant workforce, and we have started to pull together some plans around that. Recruiting screeners is also very challenging in terms of the CUM, and the CUM have really, I have to acknowledge the support they've given us, their board and the hospital, in trying to support the programme through this difficult period. So we're committed to that, and we're committed to getting that up as quickly as we can. There is a reality that we will still need a partner for the next number of years, for a significant number of years. It will take time. Our aim would be to get the CUM up to around 50% within around a 2-year period, but we will need a partner, so we need to try and ensure that we have a partner. And there is a very limited pool of companies that do this work, so we have to be very careful in how we manage our communications, how we manage our engagement, and the procurement strategy we've picked for HPV allows us to have dialogue with the market, because there's a real risk otherwise that we could be left without a partner. So we have to make sure that we can secure a partner. And we had a pre-market engagement before Christmas, which was very successful. We had a good interest, but it is a very small number of providers that offer this type of service. So we have to try and make sure that we bring someone with us in order to ensure we get through the HPV screening.
Did you check Northern Ireland for the last?
Sorry, yeah. So we met Northern Ireland, myself and Lorraine. Lorraine was actually in a rolled role in Northern Ireland and kindly joined us before transitioning. We met with Public Health Northern Ireland. They're currently in a process themselves of moving from 4 laboratories to 1. The timing for them at the moment would be a challenge. There is no significant capacity there that would address from that meeting our requirements here in terms of what we need. And we've also had discussions with other parts of the UK and with Scotland.
Thank you very much.
Sorry, no, just a couple of questions that I want answered. When I asked you about Professor Flannery, was she lost to you? And is it unusual for the department to reject advice from somebody as expertise as her? So
the loss of someone, in fairness to Gráinne Flannery, she has done huge work on cervical screening over the years, and you have to acknowledge that. She started the programme and did phenomenal work. Clearly, coming into a programme without a clinical director, and Dr. Peter McKenna kindly stepped in, even with his other roles, for the intervening period, and Dr. Harty has now moved into the role. So losing a key clinical role at any point in time, of course, it has an impact. In relation to the other point, we discussed it earlier. I don't think there's anything we can add in relation to the history and the timing of it. We've talked about the context, I guess, for the decision at the time. Personally, I wasn't there to judge that. I articulated earlier how we work with the department in terms of the advice we would give. If it's policy matters, it's a matter for the department. If it's operational matters, those are things that would be. Is it unusual for the department to reject advice from somebody as professional as Dr. Flannery? Well, we don't know that they did, in the sense of how that all operated. I think we've been through this a number of times today. We're not in a position where we can add to that. We can explain the context at the time, in terms of the difficult circumstances that were faced by GPs, by women, and just maybe just to illustrate it. I mean, our cervical helpline would typically have had hundreds of calls, a couple of hundred calls in a week. We jumped to thousands at that time, which created its own challenges, you may recall, in terms of responding to women. So there was a huge public pressure that was there.
Sorry, Smith.
Just one question you didn't answer. That's all.
Okay. Sorry, Deputy.
On the supports to women and their family in your submission, you talk about 118 of the 125 slides, and I asked you about the outstanding 7.
Yeah, so there are always a small number that are obviously work in progress with the laboratories, and the laboratories deal directly with any person's solicitor in that. I couldn't answer, Deputy, if there's one that's an active case, but I will confirm that for you and come back to you if that's okay.
Are they cases subject to legal proceedings, is what was my question?
Well, they may be, sorry. So basically the process is, if a woman will have asked a solicitor typically to take on the role for them of securing their slides. So it's rare that a woman themselves will come directly. It does happen, but generally they will do that through a solicitor. So whether the woman then chooses, in terms of taking legal proceedings, will be a matter for them. We don't concern ourselves with that. We simply look to try and get the slides to their solicitor as quickly as possible. But if your question is, are there any of the ones that are outstanding where there's a delay, say for example in the case, I'm not aware of it. I'm sure it would have been highlighted, but I will double check that if that's okay and revert back to you.
Okay, thank you.
Mr. McCallion and Deputy Smith. Now, Deputy Lisa Chambers.
Thank you, Chair, and thank you for your attendance here this morning. Mr. McCallion, I can't help but feel a lack of confidence when I listen to language around we need to manage communications, having dialogue with the market, pre-market engagement. no tendering process really underway for the HPV testing. I feel there's a disconnect between your work and the women that are affected, the 80,000 in that backlog. Your work to date has not been adequate. Dealing with the backlog has been completely unsatisfactory. There are women now waiting up to 8 months for a repeat smear result because they were seeking reassurance. Okay? So these aren't everybody, but these are women that felt, in the context of the entire scandal, women losing their lives, they felt they needed that reassurance. And they're now waiting 6 months, 8 months. And I know there's been a focus on, well, some of them are getting them back within a reasonable time. Most women are not getting them back within a reasonable time. I can talk to you about my own situation, and I'm only one of the 80,000. Having gone for a test, a reassurance test last October, I'm still waiting. I have a particular history. I shouldn't be waiting. I got a letter in January inviting me in for my routine smear. Having been already in the system and not having got my results back, you actually sent me another letter in January telling me to come in for my routine smear. So answer that question. Are you still writing out to women that are in the backlog to come back in because you haven't actually cross-checked who they are? Because that's probably adding to your backlog. You can probably tell from my tone, Mr. McCallion, and to all of you there at the table actually, that there's a huge amount of anger out there. And when news broke of Laura Brennan passing away, and God rest her, and my sympathies to her family, every one of those 80,000 women, the anxiety and the stress of listening to those stories and still not having results back. So my question to you is around, you say 2 of the 3 labs have improved their times. Which lab hasn't? I'm assuming it's MedLab that deals with people in rural Ireland. You know, people that I represent in the country outside of the cities are going to that lab. So they're looking at an 8-month wait. Nothing has happened to address that. I think the suggestion by Dr. Harty needs to be given serious consideration. Why on earth would you be writing out to women already in the system to come in for a smear test today, knowing you won't get a result back to them for 8 months? Why would you do that? It is utter madness, is what that is. If you actually delayed sending those letters, you're not blocking women coming into the system. I think if somebody comes in for the first time to get their first smear, obviously you bring them into the system. If you're already in the system, there's merit in seriously considering delaying the sending of that letter for 3, 4, maybe 5 months and dealing with your backlog. Because if you come in today anyways, you're going to wait 8 months. Whereas if you maybe delayed that letter for 3, 4 and 5 months, did the test then, you'll probably get the result back in the same time anyways. But you won't have that extra stress and anxiety, and you might get to grips with the utter mess that you're currently dealing with. And Ms. Doherty, I have to say, I listened to you earlier defend Minister Harris's decision to offer that repeat smear test when he knew there was no resources. We know he had clinical advice not to do it, okay? But he has tried to discredit my questioning and the questioning of others around that. We know he did, okay? And he can say he didn't, but we know he did. The suggestion that simply because the Minister is under pressure, because things are difficult, that they're challenging, that is justification for a bad decision that ultimately harms the health of women and undermines the screening programme. I utterly disagree with that. I think that's wrong. And Ms. Doherty, when asked about the HPV screening that you're going to implement, you yourself just said to our committee here that it has to be driven by evidence and must be safe. His decision was not driven by evidence and it was not safe. And just an hour ago you defended it. But yet you're defending the lack of implementation of the new screening programme on the same grounds. That lacks credibility in my view. So what I'm asking you here, Mr. McCallion, with your team, is to show leadership. We have a serious mess. A lot of women seriously upset, worried, anxious. That has been compounded by the lack of leadership, the lack of decision to deal with this backlog. And I want serious consideration given, not to stopping the programme, but to delaying the numbers coming in at the rate they're coming in. Because at the rate you're going, you'll be 5 and 10 years before you clear that backlog. And there will be other women that will not benefit from the new screening programme that was meant to be in last year, by the way. So there's no confidence, absolutely no confidence, that you'll have it in by early next year, whatever early next year even means. So we need timelines, real timelines. And we need a decision from you, Mr McCallion, and your team. Because this suggestion or this response that I wasn't there when it happened doesn't cut the mustard, okay? You're there now. The decision that was taken was wrong. You need to now tell us what you as lead are going to do to fix this and what you're going to do about the backlog. And we need a decision around the suggestion from Dr Harty, supported by myself actually, as somebody in the system, that delay needs to be given serious consideration, because it's the only way you'll deal with the backlog, because as you said to Deputy Smith, the capacity is not there and it will not magically appear in the next number of months. And I have to say I'm not at all satisfied with the response that's been given to the committee this morning. Thank you for your indulgence, Chair.
Thank you very much, Deputy Chambers. Mr McCallion.
Okay, so just in terms of the backlog, maybe just to differentiate, and apologies if the language around the procurement side, but that referred to the HPV process. So in relation to the backlog, Quest and COOM are both now performing in terms of turnaround times of 3 weeks for COOM and around 7 to 8 weeks for Quest in terms of results for women. So that's a positive improvement from where we were over many months ago. And we have had challenges in terms of sourcing capacity with MedLab, as you say, and we have now got options on the table that we've been working through over the last number of weeks to get those into play, which will help to shorten their turnaround times also. It has been complex. We have been trying, I can assure you, to try and find that capacity that's there. We also looked, as I said earlier, to Dr Harty at the option. I think in fairness you've made 2 points around the recall process. One is in terms of women who are in the backlog potentially not getting the recall, and I'll take that away. I can't answer that here for you, but I will take that away and revert to you, Deputy, directly. On the broader point of moving people on 3 and 5 year recalls out over a period, we will be moving them out into 2020 in terms of HPV and moving some of the problem. Now clearly we have got 2 of the labs functioning who cover the middle, the northeast, other parts of the country, the southeast and so on, but as you correctly say, there are other parts of the country which don't have that turnaround times, and we've got to address it. So we have got capacity now. We've been working actively over the last couple of weeks with MedLab to try and see how we can get that into the system. We need to ensure we do it with full quality assurance process, and we're scheduling visits to those laboratories in order to ensure that they meet the quality standard that Dr Doherty outlined earlier on today. So if that falls into place, then that would allow us to ensure that we turn that round in a reasonable period of time. I don't want to go too deep into that, if you'll forgive me today, because we are in the middle of fairly complex negotiations with them to try and get that into the system and ensure we address it as quickly as possible. And I can assure you that has been our sole focus for the last 4 or 5 months since we renewed the contracts with the provider, which was the first hurdle that we had to cross, was to keep the current providers in the programme, or the programme would have crashed. And that was the first problem. The second problem then was to try and get more capacity from those providers or from other providers to try and make sure that we address the backlog. So we have considered that, and I'm happy maybe even to revert separately with you on that. I will come back to you in terms of the point about people in the backlog. I'm not aware of that, but I will come back to you directly if that's okay, in terms of your suggestion, more than a suggestion, that people who are there shouldn't be getting recalls if they're already had their smear out of cycle in a period of time. I don't know if Dr Doherty might want to comment on 1 or 2 other of points, but just in general, that's...
Just for clarity, when I was asked earlier about the decision in relation to the out-of-cycle smears or the free smears, as I said, and I know this doesn't cut mustard with you, but I was not involved in that decision-making process at the time. I was not even working in the programme at the time. On reflection, all I can do is try to understand why one might have taken that decision to offer those smears. Clearly, there was a crisis situation in relation to confidence in the programme and a heightened anxiety among the population of women who would be eligible for screening as to whether or not they could have a test or have confidence in their test. So I would imagine those kind of things might have driven decision-making around that time.
Thank you.
Follow-up question on that, Chair, if you might.
One question, so Deputy, yes.
Mr Harty, again, I mean, I hear what you're saying to me, but your professional opinion was sought at the committee, and on one hand you're saying that decisions must be evidence-driven and safe, and on the other hand you're suggesting that public pressure is sufficient to justify a decision. And all I'm saying to you is I disagree with that. That is the responsibility of being in Cabinet. That is the privilege to serve in Cabinet, but the responsibility that comes with that. And decisions you take have impacts. They have consequences. And you must always base those decisions on evidence, not on popularity, not on populism, not on public pressure. It has to be taken, what is the right decision for those that would be affected, for those that you actually serve and that you look after. And that's the point, that in all of the chaos and all of the madness, we must always revert to making the right decisions based on the right reasons. And my view is that decision at the time by the Minister was not the right decision and was not based on the right reasons. And when asked for a professional opinion, I think you're well within your rights to say that, because that's how we learn from these situations. Mr McCallion, again, talking about exploring options, working through it, it's now April 2019. This decision was taken last May. The backlog was becoming evident in August, so we've known about this for quite some time. It's no longer acceptable to say we're working through. I don't actually accept that you can't outline details today to our committee, because you knew why you're here today. So I think to ask for timelines, definite timelines, and a very simple question: when will you clear the backlog? And you should be able to answer that. Okay, because if you know the capacity in the two labs that you've made improvements, that one is doing 4 to 5 weeks and one is doing 7 to 8 weeks, and that MedLab is, well, we don't know where it is. Okay, that's not acceptable at this point in time. And rather than reverting to me personally, I would ask that you revert to the chair of the committee and that it be circulated to all members, and that you tell the public immediately what's happening with those negotiations and when that backlog will be cleared. And if you can't give that information to date, then we need a decision from you around the out-of-cycle smear test, women already in the system. Are you going to continue to issue letters to come back in after their 3-year period is up? Are you going to continue to add to the system without the capacity being in place? That is your decision to make, not mine. That's your decision to make. And the question around somebody in the backlog, if you're in the 80,000 and you've had your repeat test and you're waiting for a result, nobody should be getting the routine letter that I received last January. You need to look at that. If you weren't aware of it, you should have been aware of it.
Thank you, Secretary.
I was just briefly going to say, just in terms of the backlog, Deputy, when we have a definitive position, the first people we'll write are the people who are in the backlog. But until we have a definitive position, we can't do that, and we have to make sure we have those. It isn't a case that we just pick a date and ensure that we would love to have had this resolved months ago, but this is not easy to source capacity in the market that we're in at the moment, and in terms of attracting people into Ireland. I need to reiterate that very clearly, that this has been hugely challenging to try and identify capacity. If it was there, I can assure you we would love to have plugged it in a long time ago. We now do have very strong options. We're trying to close those out, and once we do that, we will then revert to the people that are waiting, because they are, as you rightly say, the most important people in terms of understanding what's happening. Thank you very much, Mr McCallion. Now, we've been here for 3 hours, so I am obliged to offer you a break of 10 or 15 minutes if you wish to take a break, or if you wish to continue. I think we're fine to continue, Chair. Happy to continue? Yeah. Thank you very much. Now, that completes the first round of contributors, so we're going to go back for a second round. Perhaps we could limit it to 6 minutes-ish.
We'll see how we get on.
Or less.
We'll do our best, thank you, Chair.
So, sorry, what's for non-members? Is it 3 or is it just whatever you're having yourself?
Something less than 6.
Thank you.
Okay.
Deputy Donnelly.
Thank you.
Pardon?
You're very reassuring.
I just want to reflect back something, Mr McCallion. You said earlier on, I think quite nobly, you sort of took responsibility for a lot of what's happening upon your team, upon the HSE. And actually, I think you're taking responsibility for the wrong thing. I think largely the crisis of confidence was caused in the Oireachtas. I think it was caused by politicians. I think it was partly caused by members of the Oireachtas outside of government. And how the Oireachtas reacted. I think the Oireachtas conflated clinical outcomes for women with non-disclosure. And I think the Minister largely created the issue. He was warned weeks in advance that the Vicky Phelan case was going to emerge. He was warned that it was likely to cause a crisis in confidence. They did no preparation whatsoever. They've admitted that. Within 48 hours, the Minister expressed no confidence in the senior management team of Cervical Check without meeting them, never met them, never asked them for their opinion. That was largely taken as the government having no confidence in the Cervical Check programme and having created anxiety and fear. Then an offer of a free test was made, and we now know that actually there was very strong clinical advice not to do that. So I do believe that Cervical Check failed in not closing the audit loop, though it is worth noting that they failed to complete an audit loop that no other programme on earth even tried to perform. That's what they failed at. They failed at the end of an audit in trying to be the best programme on earth in terms of audit and feedback to the women involved. And to suggest that that failure would lead to a crisis of confidence, clinical confidence for women, I don't believe that's true. I believe actually the mishandling of this by the Minister caused the crisis of confidence, which we now know caused this huge backlog, which we now know has caused no date on the HPV test being introduced, and 79,500 women waiting for their results. I think what you do need to accept responsibility for, and you may well do, is the response to that. So I don't think your team created this mess at all. I think largely this mess was created by the Minister and by the government, aided and abetted by the Oireachtas. There was certainly loose language within the Oireachtas which was very unhelpful as well. But it is your mess to clear up. And I was deeply disappointed when I got a response in the last few days saying that the number had gone up. So the last time we met here, the number was 78,000. And I think it was all of our expectation that when we met up again, that number would have fallen. That the number of women waiting, a lot of them experiencing huge anxiety, would have fallen. But in fact, it's gone up, which is extraordinary. Because actually the free test, which caused all of this, was stopped several months ago. So I was expecting you to come back here and say it was 78,000, we've got it down to 55,000, and we'll have it cleared by whenever it is, right? And I think, unfortunately, your team does have to accept responsibility for some of that, notwithstanding the very difficult international context, which is what I want to come to. You stated that our market engagement has identified significant challenges and concerns in the provider community. What's the problem? Is it that there just isn't the cytology capacity anywhere? Is it the fact that there is, but international providers are scared of the political or reputational or litigious context of Ireland? Because it's galling to hear, this is not your fault at all, but it is galling to hear that women in a phenomenal public screening programme, one of the most successful public screening programmes of its kind anywhere in the world, that women are waiting 8 months for a result, and what they hear is, well, we can't get cytology capacity, but if you want to pay 100 quid, you can get it in 2 weeks. So clearly cytology capacity does exist, because women who can afford it are just paying for it. You know? And one of the wonderful things about the screening programme is it didn't fall foul of this awful two-tier healthcare system that we have. So if it is the case that you simply can't source, that the capacity isn't out there, how is it that women can bypass that and find it by paying? And if it is in fact the case that there is cytology capacity out there, but they're refusing to provide it to Ireland, to the HSE, why are they refusing to do so?
Thank you, Deputy.
So there's probably two questions there, Deputy. Yeah, so the first one, in terms of the scale of the capacity we need to address the backlog, the private capacity that's there is minuscule in the context of our public challenges for our public screening programme, just to put that in context in this jurisdiction and indeed in other jurisdictions. So if you look at the NHS, they have a huge backlog themselves. It's been reported widely in recent weeks over their own challenges for different reasons to the reasons that we have our challenges here. So I think that isn't a significant factor in the scale of the challenge we face in this. I'm not saying it isn't a wider issue, but it isn't a factor in terms of our challenge now, which is, as you rightly say, to get the capacity in place in order to get the turnaround times back for women. We have made some inroads with 2 of the laboratories where the turnaround times are down to more reasonable levels. One is back to the levels pre-crisis. And we're working with MedLab then in terms of solutions for that, and we have identified capacity now with them. And some of that is taking the opportunity where, for example, if a site moves with HPV primary screening, that releases cytology capacity that we then try and step in quickly to avail of in order to ensure that we can use that to help us address our backlog and get the programme back to an even keel in terms of where the capacity equals the demand.
So it's not an issue, you think, with Ireland? It's not that there's capacity out there and the international market is cautious of engaging with the HSE.
So no, I concur with your assessment in terms of the wider, so when I referred earlier, so that's in terms of the backlog. We're trying to identify capacity within the current providers that we have for the backlog. And the reason for that is the lead time to connect a new laboratory is significant, and that would add further delays. So we have also identified potential capacity in other jurisdictions that we may be able to avail of or may be able to encourage to compete with for our HPV project. Your early assessment in terms of the risk within Ireland, or the perception perhaps of our market and of Ireland is fair. I think there is a lot of concern in the wider community in terms of that, and that's one of the challenges that I mentioned earlier in the market engagement process. And just maybe to simplify it, the normal tender, as we all know, is you put out your specification, people bid, it's closed, and you see what comes out the far end and you assess it against various measures. If we did that, the risk is that, given the factors you're saying, we wouldn't understand what the market is feeling and we wouldn't be able to reflect it in our tender. The option we've taken allows us to have a dialogue, which allows us to make sure when we put up specification in there, we have a good chance of getting providers to bid for that. And that's trying to address the risk.
Can I just ask, right, I understand on an ongoing basis there's a public procurement process and it's very detailed and you've got to do it in a very clever way. But we are dealing with a backlog of 80,000 women.
Yeah.
The question I'm asking is, in the context of finding temporary additional capacity to make sure that those women get their results on time, what's the problem? Is it the fact that international providers are very nervous of dealing with Ireland? Is it that they're asking for prices we're not willing to pay? Is it that they're asking for indemnity against risk that we're not willing to provide? Because it appears to be the case that if you're willing to pay privately, you can get access almost immediately.
And I think the private access that's been reported is misleading in the context of the backlog. It is so small, Deputy, in this context that that's not the factor. The factor are the two other points you mentioned. So one is environmental and the other is cytology availability. We have, as I said, source capacity with two of the labs, or introduced capacity to help get the backlog down, and we're now working to finalise the plan with the third lab to try and get that capacity in. And once we do that, as I said earlier, then we would write to the people who are, as Deputy Chambers articulated earlier, anxious waiting for the results in terms of
Thank you. Final questions. Thanks, Chair. I'll just go through them very quickly. Have you a date? You didn't the last time. Do you now have an expected date for the availability of the HPV test? Question one. Question two, what is your view on temporarily suspending tests in order to clear the backlog? It's been reported, Deputy Chambers has outlined it, it's been reported in the media that one of the labs is actually proposing that as well. What's your view on that? And finally, there is a number of women who were recalled because the test date had expired. Have all of those women now been retested, and have they got their results? Thank you, Chair.
Thank you, Donnelly. And maybe just brief answers to those questions, if you can, please.
Sure, so maybe I'll take the last one first. So 800 of the 2,500 that were subject to that HPV expiration test, those results are back and have been distributed out to women. I couldn't tell just here the distinction between those that are gone out and those that are going out. The target then is to complete the balance within a 2-week period. And of the numbers that were there was 2,500 that requested that test. Others may choose to come in over the coming weeks, but there was an initial surge, and I would anticipate the additional numbers being quite low.
So the full 2,500, if I understand you correctly, will have their results within 2 weeks, is that right?
Yeah, so the aim from Quest in that context was 800 results are already back to us, and the target is to complete the balance then within 2 weeks from, I think it's from next week, Deputy.
Okay,
so
thanks.
The point then in terms of considering changing the Chair's point earlier, we've looked at that and we've kept all options on the table, but at the moment where we believe now we have capacity identified and a plan that we can secure, we're trying to nail that down over the coming week or two, including the QA visits. So the reason we can't be as specific as you'd like to be is we need to schedule those QA visits, we need to tie down some of the contractual details on that, and then once that's in place, we will, as I said earlier, write to those people who are in the backlog to give them that time frame. So that would be the priority for now. But we have looked at several occasions in terms of how you would logistically manage moving people who are on normal 3- and 5-year recall periods out But as I say, it also creates a problem straight away in 2020 because then you're loading those people, you're shuffling everything effectively, you're not changing it. The example I think that Dr. Harty gave earlier, saying the Netherlands, where they paused the programme, they had the advantage, they were actually able to see a larger number of people. So instead of missing people, if you like, they saw, say, the last 6 months, in the previous 6 months, then had a pause to let HPV come in. So it was a slightly different model to the scenario we face here.
So just on that, if I understand you correctly, there is no projected date or target date for introduction of the test, is that right?
So the key date will be determined by the tender. That's really the factor. So if we get a provider through that tender process that can interact with us very quickly, then we believe we can achieve it in a shorter time frame, end of this year, early next year. That's the key thing at the moment. So we're going out to our contract ad now. So the procurement process is running, just to give that assurance. It allows, as I said earlier, the way we mitigate the risk of the environmental factors that you mentioned earlier is to allow a dialogue with the market. That's possible through a certain procurement process. The contract notice will be going out in the next couple of weeks for HPV, and that will allow us then to see whether we can get a vendor that will work with us around that.
And just on your
Deputy,
view that you temporarily suspend
Deputy, sorry, I'm going to
programme.
have to move on.
I was just reflecting, I think there's language here, but effectively really what you're talking about is moving people on 3- and 5-year recalls out. You would always still want to see new women because they're high risk. You would also have people from colposcopy, people on short-term recalls. So there are categories of women you would have to see. You wouldn't suspend the programme for those. You couldn't. And you would simply be moving some of the standard recalls out. We've looked at that option, but at the moment, if we can secure this capacity, clearly that's the preference, and that's where we're focused at the moment.
Thank you, Deputy Donnelly. Deputy O'Reilly.
Thanks, Chair. So you say you've looked at the option of temporarily suspending the programme for women who wouldn't be symptomatic, but just would be in the normal course of the programme, getting their letter to just go along for a normal smear test, a routine smear test. But you're not going to suspend it because you believe that you're going to source the capacity from these additional labs when the QA and everything else is completed. In the event that you can't source that capacity, and I don't mean this disrespectfully to anyone in the room, but you haven't exactly covered yourselves in glory in terms of sourcing capacity, and I understand that the Minister wasn't helpful in that either. So in the event that you can't source that capacity, is that then back on the table? Obviously not for those women who are in a high-risk category or for those new women who may be in a high-risk category, but just for the ordinary routine run-of-the-mill test. Will that then be back on the table if the capacity can't be sourced? And could you just identify, do you have a timeline for or a deadline for when you're going to make that decision? Because so for all the while that this goes on, women are waiting and they are anxious. Of course they are. There has been confidence in the programme has been undermined. I take every opportunity, and you alluded to this earlier, to say to people, screening saves lives. You should always go and get tested, always. Having said that, notwithstanding the fact that we try to do that, you understand that women are nervous.
Absolutely. So it isn't so much really a suspension, I guess, because the programme still functions. I think, as the Chair articulated earlier, it's really moving people on 3- and 5-year recalls out.
Just for suspension for that group is what I meant,
sure.
Yeah.
So in terms of timeframes, I mean, we would hope over the next month that we will have certainly closed that out, because there's a number of elements. So we have identified the capacity. We're working through the contractual piece at the moment, the terms around that. We're also getting the pre-inspection piece, which is trying to gather the information to make sure the labs meet the quality standards. And then, as Dr. Harty said earlier, that would be followed by quality assurance visits to that. So that's the sort of timescale that we're trying to look at around it. We've worked up all options. You know, we've constantly been looking at that, as I said earlier. But there is a downside in that you're simply moving the problem. Yes, you help alleviate something now, but you create another problem that you may or may not have capacity for later. So we've looked at variations in that in terms of time periods around it. But our focus really over the next month now is to try and nail down this capacity we've identified, get it into place, and that will hopefully help then to alleviate the backlog. And as I said, for 2 of the laboratories who managed to do that, we do need to do it for the 3rd. And they're working closely with us, and they have been over the last number of weeks to identify that capacity.
Okay, thanks. Just with regard to something that was said earlier in relation to how the decision was taken and what exactly it was that was offered to women. I took the liberty of checking on Twitter, and what the Minister tweeted was, "Have heard from women today who have had smear tests and would like a repeat test to reassure them. I'm arranging for this facility to be available, and the state will meet the cost of the repeat test. Arrangements on how this will operate will be outlined next week." So effectively, the public announcement from the Minister was that anyone that wanted a test, it was nothing to do with bedside or a doctor or anything like that. He offered a free test to any woman that wanted it, and it's now clear that he hadn't done any homework, and indeed that was against the only available clinical advice, which he either got and ignored or didn't get. Either of those options, obviously, is very concerning. I'm sure it's very concerning for you, Ms Doherty, as the head of the programme, that your predecessor would have been given advice and that advice would have been ignored. So I wonder if you would have a comment on that. You know, as the person who is going to be the lead in this area, do you expect that if you raise an issue of concern to the Minister or indeed senior officials in the department, do you expect that you'll be taken seriously, or would you accept that that your advice would be ignored in that way?
Okay, thank you for your question. In respect of my own position and what advice I might give departmental colleagues, I would absolutely expect that they take my advice on board and listen and decide how they're going to brief their minister. In respect of what happened before and what advice was given and how it was communicated, I can't comment on that.
Yeah, but I mean, the same personnel are still involved, so would you be concerned that you would be given advice and that advice would be ignored? I mean, that appears to be what has happened.
Well, I can comment on my own working relationship with the department, which is very good. I have direct communication with officials in the department, with medical colleagues and also senior civil servants. So those relationships are working well. We have regular meetings and briefing sessions. So I haven't had any experience to date of any advice that I might have given being ignored.
No, I'm asking a different question. I'm asking, are you concerned that the advice of your predecessor was ignored? Does that give you, in your current position, cause to be concerned? And I have to tell you, if I was in your position, it would give me cause to be concerned, because your predecessor was a qualified person and a person who, you know, was definitely capable of giving that advice. So in your role now, given what we know happened, are you concerned that your predecessor's advice was ignored?
As I said, I can't comment on how her advice was given, received or acted on. That's not within my remit to cover. But what I can say is what I see around me now is a process of meaningful engagement with the department on all issues in relation to cervical check. And I would expect that any advice I give would be considered and advice given to the Minister based on my clinical advice. So I don't have concerns at this point in time that that is going to happen. I think, as I said, I'm quite confident in the relationships I have right now, and who knows what will happen in the future. I
dearly wish I shared your confidence, Chair. I just have very brief questions, and I'm conscious because I did go to check on social media for that tweet, and I saw a tweet from Stephen Teep reminding us that we should also not just be focusing on the past, but on the future. So in that regard, I'm going to ask you, what is the status of the steering committee? Because I know that some of the members on the steering committee are concerned that efforts are being made to somehow sideline the committee or disband the committee. So you might comment on that. And then also, just as things stand currently, if a woman, and I just want you to walk through this process with me if you wouldn't mind, if a woman has had a clear smear test in the previous 6 months, but is symptomatic today and goes back to her doctor, can she expect that her test will be fast-tracked, number one? And number two, how soon can she expect a result back? And I'm not, you know, this woman she's not going to pay for it. She's in the public system. So I'm wondering how soon she'll get her test back. And if you can comment also on, is there going to be a difference in the case of a woman who is symptomatic? Can she expect her result back quicker or quickly? Can you give us a time frame? And also, can she get it quicker if she pays for it? Thank you.
Deputy, I might take a start on that, if that's okay. Thank you. Just to reiterate that point, it's really important to emphasise for anybody listening or watching the difference between people who are symptomatic and people in a screening programme. For people who are symptomatic in any of those 3 screening programmes, be they through bowel symptoms, or a breast lump, or indeed through vaginal bleeding in the case of cervical cancer, the screening programme, to be blunt about it, has no relevance to them. They must go straight to their GP.
Yeah.
And we have urgent access pathways for these patients that we measure and report on monthly. And I would expect those patients would go straight, so bypass screening, go straight to a general practitioner. And the general practitioner, I would expect, Dr. Harty, as you know, would refer that patient straight to urgent cancer referral clinics.
And in relation to how quick that's going to happen?
We on endoscopy, for example, for bowel screening, and breast clinics, we have 8 cancer centres, as people know, and we have endoscopy in a large number of centres. But we measure performance for urgent referrals for each of those centres, and we interrogate our hospital groups and those hospitals monthly on those performances, and they're published on our HSE website.
That's excellent. So the fact that she has had in the previous 6 months a clear smear test, is not going to impact on that. If she's symptomatic, she's straight away fast-tracked.
Absolutely, Deputy, and it's a really important question to ask. If you're symptomatic, the easiest thing is to think the screening programme, bypass the screening programme, go straight to your doctor, get referred for urgent referral. That's the important message.
And the previous result will have no bearing on it?
Absolutely not, no.
Okay, and just with regard to the steering committee?
So the steering committee continues to meet, and we had a meeting, I don't know, was it last week or the previous week, Deputy, so it's not a committee is convened by the department, and the HSE participates, as do the patients and others. So we've certainly met in the last couple of weeks and will continue. I think we've another meeting scheduled. So
there's no plans to disband or sideline the committee. You're happy that it's working well?
We're functioning, yeah, and in fairness, as you said yourself, I think the patients are providing a unique input to that. I mentioned it myself earlier. The perspective that people bring and the challenge it brings is a good one.
Yeah,
it's a healthy
but it's the
one.
patients that are concerned.
No, I'm aware
of
the wider concerns. I suppose the HSE are participants in it. All I can say is, look, the committee is continuing to meet. We're continuing to participate. We're continuing to meet with the patients around all.
But you're happy that the committee is performing its purpose, that it's useful, that it's advisable to keep the committee going?
Absolutely, the committee is functioning, and we're, the work is continuing, and we're continuing to implement Dr. Scally's report, which is one of the primary objectives of that committee.
Henry, you wanted to come back in?
Deputy, I wonder, could I just come back, Deputy O'Reilly, on that issue, because I think it is an important point for screening, that a negative screening result does not mean that somebody does not have cancer, and it's a really important public message for all of us to convey.
That's precisely why I asked the question, Mr. Henry, because I am conscious that sometimes we get, that we're not clinicians, with the exception of, yourselves and Dr. Harty, but that we, sometimes we have a public function to put information into the public domain, which is what I was seeking to do.
If I could use Dr. Harty this forum to say that, because for bowel screening, it's the same applies, and for breast screening, simply because somebody who's attends, based on population health screening, attends and gets a negative test, does not mean that their symptoms are not due to cancer. It could be.
I suppose the point you're making is that screening is for people who have no symptoms whatsoever.
Correct.
Once you have symptoms, screening is not the appropriate service to attend.
Nor do the previous tests have application to your symptoms.
Absolutely. Now, Deputy Durkan or Deputy O'Connell?
Yeah,
Deputy Durkan.
Yeah, thank you, Chairman. I listened carefully as I could to the various points, and I think we need to think back a few months, for example. When the issue first became a public issue, if I were Minister, I would want to know what went wrong. And the Minister, quite correctly, did everything possible to ensure that all the buttons were pushed that could be pushed to bring a new era and a new confidence into the system. Now, as you know, Mr. Chairman, I've been a critic of the structures of the HSE, not about the personnel. The fact of I don't and will never agree with the structures because, to my mind, it is not workable. I asked the question at this meeting: who is the boss, the Minister or the HSE? I have to raise that question again. So the Minister, quite correctly, made the decision to reassure those women who may be under the illusion that they were either cancer-free or maybe not so, in order to address the issue of anxiety. And I fully accept Dr. Doherty's response to how you respond and how you deal with the situation that arises. However we deal with the situation and however it was dealt with before, it wasn't adequate. It didn't work right. Because if it did, there wouldn't be a problem in the first place. So if somebody said that a clinical decision was made, a clinical decision wasn't made. A management decision was made by a clinician on the basis of the experience that maybe it might happen one way or maybe it might. The critical issue at that stage, Mr. Chairman, was the reassurance of the public that the system that was in place was adequate and that those who had gone through screening, be negative or positive, could be reassured that there was another test coming up. The issue then was to separate the two, to create a second line, not a situation that would add on to a waiting list or not on to the problem that was already there, but to have a second channel now to deal with that review for the women who might have a concern and who might not have a concern, or might have a condition, or might not have a condition. That was where the problem arose, and that's what needs to be done at that particular stage. That's a management problem too, I have to say. It's how you manage the situation. And I'm not being at all critical. It's just that, you know, we have a lot of experts. And somebody mentioned, you know, we're not clinicians. That's right. We're not. But we have a duty to raise the issues and to query whether or not the system is fit for purpose and whether it does the job. To be fair to the clinicians as well. Because if you don't have a system that is adequate to meet the cause, to meet the caseload, then your job is going to become impossible. No matter what you do, there's going to be a problem down the tracks. And there will be another issue coming down the tracks at some time in the very near future. So I want to make it quite clear, you know, it's a very easy scapegoat to pick out somebody and say, you're responsible for this, be it the clinician or a minister or somebody else. The fact is, a situation arose that was totally unacceptable. And that's a fact. That's not a theory, that's a fact. It was there, plain as the pikestaff, in front of everybody. The system hadn't worked. Now, there was confusion as to whether or not it was a diagnostic system or a smear system or just a check system, and we know what that was, 80% accuracy and so on and so forth. Some people acted on the basis that it was 100% accurate, which of course it wasn't. And we came to the conclusion very early in the stage that it was the wrong system, and that we have to have a more accurate system, because you can't base your political or your medical reputation on the line unless you have a reasonable degree of reliance on whatever you're dealing with. So it goes back to capacity, and this has come up again and again and again. Sadly, the capacity wasn't there to do the job as it should be. There are various reasons for that, and we can say, you know, was it a lack of money? Was it a lack of personnel? Was it a failure to attract clinicians from abroad and so on? Whatever it is, it was there. It was there then and still there. So, to be fair to all concerned, you know, I can play politics with this as much as anybody else, and I'm sure the Minister could if he was here as well. Playing politics doesn't address the issues of the women, or the concerns of the women. Very easy to do that. Sound bites left, right and centre. And we can accommodate that. I can accommodate that too. But what I want to emphasise at this moment, Chairman, as I did in the beginning, I believe that we now need a clear indication that we're, as I said before, attacking the problem at both ends. We're containing the existing one and making inroads insofar as waiting lists are concerned. I got a reply to a parliamentary question last week in another context, and I nearly had a seizure when I read it, because it related to a condition that was progressive, that was serious, and whoever dictated the reply obviously decided, well, this is a stupid, ridiculous politician. They won't know the difference. Oh, we do. We do know the difference. And we know cynicism when it's incorporated in a reply as well. And we know mind your own business when it's incorporated in the reply. This is our business. That's what we're here for. And when we ask the question, it wouldn't be a good idea necessarily to come to the conclusion that the stupid idiot who raised the question in the first place doesn't know what he or she is talking about. So we have to be alert, we have to be on the ball, and we have to be able to do the job. And that's why I've said it many times in the past, Mr. Chairman, that when the health boards were in existence, what happened in a situation like this was there was a crisis meeting. That evening, that day, not a week's time or anything else. And by the following morning, we all knew what was happening.
Sorry, Deputy.
And I know this. This is fundamental.
Question.
Chairman, I won't go into. I measured the time for all the other speakers as well, just in case that to prove my point.
But just
yeah, no, you can measure my time as well. I do insist on taking adequate time to deal with the subject as well, and I try to do that. And with the exception of this morning, I've been here every morning at the start of the meeting and right through to the end, which is more than being said for a lot of people. I mean, right through to the end, not by making a soundbite or walking out.
Are you deliberately delaying?
If the deputy waits, you'll find out. The point that I wanted to make there, Mr. Chairman, is this: is that we need to know now, an honest opinion, as to whether or not we can be assured that we will find in 2 weeks' time or 4 weeks' time an improvement in the situation that we can say, well, okay, we're moving in the right direction. Or will we find again in 2 or 3 weeks' time that we have another problem that we didn't see before, in which case we'll be in a worse situation. But worse still, public confidence in the system will have diminished further in that length of time, and that has to be dealt with. It is now a crucial and critical issue. Excuse me, I also have a cold, Chairman. You might be able to administer something before the meeting is over.
Will we put that question to our witnesses then? When could we realistically see an improvement in the backlog?
So I think, Deputy, just the point on the backlog, I think what I outlined earlier to previous questions is that we have seen improvement in 2 of the labs. We're working with the 3rd lab. We're working to identify that. We have identified the capacity. We're working to close that out over the next number of weeks, and that's the point at when then we would communicate with people who were in the backlog first in terms of what the suggested time frame would be for them, to give people some level of assurance, if possible, around the delays.
Thank you.
We shall wait and see, Mr. Chairman.
Thank you.
I should have said to my colleague that I'm a member of the committee and I'm entitled to raise questions as often as I like. And when I go into other committees, I don't delay either, nor do I delay in this committee.
Thank you, Deputy Durkan. Deputy O'Connell.
With the risk of being accused of catching whatever Deputy Durkan has, try and keep it as brief as possible. And we have, obviously, the benefit of hindsight here, and we've had many history lessons and assumptions here this morning. And just to make it clear, because I've been very straight on this since the start, when the offer of an additional smear was given, and correct me if I'm wrong, because imagine, Mr. McCallan, you probably know the answer to this. I don't follow Twitter in terms of where I get my official press releases, but the CMO made a press statement, and I quote, "For any woman who has had a cervical smear test and where the GP feels that she should have a further test as part of a reassurance, the Minister has asked Cervical Check to make arrangements, including payment provision." So in terms of the first point in the correspondence we got last night, I just want to make it clear the GPs got paid for this. Second of all, there was 2 strands to the payment. There was a consultation payment, and then there was a further payment if the procedure happened. So in terms of previous comments, where that it was a free token for a smear that I mentioned, but in terms of the Minister offering a free smear, the Minister is not a medic. The Minister acts on medical advice. And I would also point out that if making medical decisions, and I speak as someone who has worked as a clinical pharmacist and has worked in community pharmacy for 15 years, if it was as simple, and we've 2 very well qualified doctors in front of us today, if it was as simple as making clinical decisions based on just data, we wouldn't need any doctors or pharmacists. We just throw data into a computer and it should throw an answer out the other end. So doctors need the autonomy to make, I firmly believe that doctors need autonomy to make the decisions that they need to make, be it with regard to any men, women or otherwise, in the comfort of their practice with their relationship with their patient. And the very fact that the payment was divided into 2 strands, consultation plus procedure, points out that the power was in the hands of the GPs. And I will further point out, based on anecdotal evidence and not any major study, I live and work in Dublin, have busy city centre pharmacies. People were presenting terrified. And when we look back at the history, I remember the chair, and I hope I don't attribute the wrong questions to you, Dr. Harty, but the custody, even who owned the smears, we didn't know in the early days. When Dr. Grone, or Professor Flannelly went on Morning Ireland, she could not tell how many women were affected. In a correspondence, Dr. Flannelly, and I'm not taking from her role, I know she did huge work and started off all of this, but she did not know how many women, and also, to my mind, there was a letter of July, I think, 16, where she specifically pointed to non-disclosure to the families of deceased people. So, on one hand, we have a document released overnight, and some people are taking it as gospel, and on the other hand, we have historic references to a person whose contribution, to my mind, on Morning Ireland, contributed massively to the stress around this. And even though...
Well, Dr. Flannelly isn't here to defend herself, so just to keep that
okay,
in
I'm
mind.
keeping it as tidy as possible. And in terms of scaremongering, the normal response for most women was that they were terrified whether the smear they'd had 3 years or whatever, 2.5 years before, just no one read it. That was almost a perception that it was sort of in a shelf somewhere and no one looked at it. So it's all fine looking at these things, looking back at it, but if we take ourselves back to where we were here and in PAC, and many of you were in here, and many of you were treated in a very, I suppose, aggressive way, but that was an adversarial, it was very adversarial, but that was stemming from the I suppose, all of our concerns about the system that we know has improved the lives of 65,000 people since it started. In terms of capacity, there's a comment made that that the Minister wasn't helpful in regard to sourcing capacity. Did that happen? Is there any evidence that the Minister was in any way, there was any issue with capacity? What's the evidence for that comment, or can it be retracted? Yeah, no, you didn't. Fairness, yeah. No, somebody here did.
Sorry.
I did, I'm sure.
I'm just wondering where the evidence for that comment
I didn't pick anything up on that.
Because the Minister's not here either to defend himself.
Yeah,
so.
I didn't pick up that comment from anyone, Deputy. So.
Oh yeah, we can get it back and maybe have it retracted next week if we can get it on the audio. In terms of, there was a reference earlier on, and of the HPV reflex, Dr. Doherty. Was that the word you said? Can you just maybe outline that? Because there's sort of, like, we're in cervical screening and we're transitioning to HPV, but if there's HPV reflex going on, so we're sort of in a transition period already, would it be fair to say? Because it's almost, I sort of thought there was like moving from A to B, but really it's a transition. So maybe you could just outline the HPV reflex comment you made earlier on.
Okay, so what I mean by reflex testing is, in our current system of cervical screening, a woman has a smear taken, which the first test on that is cytology. And if there is any indication of any abnormality on her smear, she has a reflex HPV test. And the test is to identify what we call oncogenic types of human papillomavirus, particularly types 16 and 18, which are responsible for 70% of all cervical cancers. So if a woman has a change on her smear plus a positive reflex test, that highlights the fact that she needs to be prioritised in terms of management and referral. So that's what we mean by reflex testing. It's a secondary test. It's not the primary screening test.
It's on the same slide, but it's on the same product.
Yes, but it's not the primary screening method. The primary screening method remains cytology.
And when did the reflex test start? Has it always been the case?
No, 2015. So it is a gradual transition, Deputy, as you say, in the sense we had pure cytology, and some jurisdictions didn't introduce the reflex test. We've done that, and as Dr. Doherty has said, then the plan is to transition where HPV becomes the primary screen and cytology becomes almost like a diagnostic on the HPV test.
Again, and I do feel, I mean, I totally get that Professor Flannelly isn't here, but I also, the Minister is not here. There's another comment made here this morning that the the clinical advice was not taken by the Minister, and that this would harm women's health and undermine the screening programme. And I think that's a fair charge coming out of this committee this morning, because, to my mind, the sole focus here is getting this sorted to the future, and we move forward from where we are, where many of us were concerned about whether the whole system would collapse. And I think in terms of it's not great in terms of backlog, and as I pointed out in my first contribution, it's not really the capacity issue. You know, we don't seem to be getting traction there. And I know other members have asked, and it's very, very difficult to get timelines as to when we can eat into that backlog. But that's a major concern for us here, because, again, there's a couple of comments about it could take 10 years or whatever to get through this. Well, obviously, if the progression of cervical cancer is 3, 6 and 9 years, well, that's sending a message out of this committee that's incorrect, and which will feed the scaremongering and feed the anxiety around this issue. And, you know, there was other contributions about, you know, the Oireachtas here contributed to it. I believe most people in the Oireachtas, the vast majority of people, were trying to get answers, real answers, and try and improve the system. But I think moving forward from today, the day of political point scoring on this issue, and the historic look back at who did what and when, you know, we could be forever looking into this. To what end? At the end of the day, the point of this is to save lives, to give better outcomes for women, and that's where we should be, and families, and also the whole exposure of the open disclosure area that has been, as many of you I'm sure have dealt with in terms of obs and gynae and that in the past. So perhaps in terms of how do we eat into this backlog, and how do we hammer home the message that screening saves lives, screening improves outcomes in terms of fertility and people's life experiences, and it's not 100% that it's the healthy population we screen, that people with symptoms move to a different phase, that people who are at higher risk move to a different area. I just don't want the message going out of this committee that there's 80,000 people who are likely to have cervical cancer sitting in a room. I understand that's not the truth, Dr. Henry, but I just don't want that message going out of this committee, because we don't want additional erosion of our screening and our engagement.
Deputy O'Connell.
It was just to reinforce the point. I think it is really important that while we all accept it's not a good position in relation to women waiting on the results, but that the clinical risk is very, very low in this context, and equally that we are focused on trying to resolve the backlog so that people who are waiting, and we have made some inroads, as I say, not enough, but we have made some inroads, and our focus is to try and address it through the capacity, and we'll look at all options and continue to do so as we get through this over the next while.
I suppose the point to be made there was the screening programme, one of its benefits was you got a result within 4 or 5 weeks. And that's broken down now. So, of course, the risk is low, but the reassurance is now
absolutely.
missing.
And I'm not in any way, I just want to be very clear, we fully recognise that, and having talked last week to our own staff who man the information lines, you described it well yourself earlier, in terms of people are anxious, people are worried, and we are trying to address that as quickly as we can, but we also have to make sure we do it factually. We have to make sure we can deliver on what we go back to people with and not give them false assurance, and that's what we need to do.
Thank you.
In terms of information for women out there, we had the leaflet, the cervical check leaflet, in here whenever a year ago. Has there any work been done on that? Because in the aftermath of this, many GPs, to my mind, didn't understand or didn't know the limitations of the test, in 70% or 80% depending, and I suppose very concerned that they didn't relay that to their patients perhaps in the correct way. I actually wasn't aware personally of the limitations of the test. So in terms of, and I felt that the leaflet we looked at in here at some point was very wordy, no one was going to engage with it. It wasn't essentially fit for purpose, because if it was fit for purpose, there wouldn't have been as much, I suppose, false information or ambiguous information out there. So what work has been done in terms of that information going to the woman who's either within the system already, or who's maybe a girl in her leaving cert year, been through the HPV vaccination programme, moving into perhaps contraceptive end of life and all that? How are we communicating in a better fashion to what we did previous to this crisis?
So, thanks for the question, Deputy. So, I agree. I referenced it earlier on. One of the things that Dr. Scally did as part of the scope and inquiry was he made a number of recommendations in relation to the information that we give to women and service users of the programme. So, one of the outputs from the work that he did was that we undertook a complete overhaul of all of the information that we provide to women and to other service users. So, I have the old leaflet and letter that we previously were providing to patients with information about the screening programme. We now have a whole suite of information that patients get, depending on where that patient is, or depending on if they're a healthcare provider, and so on and so on. All of that was done in consultation with patients who were affected directly by the issues that arose in 2018, and also a wider pool of patients that we work very closely with in all of this. So the range of materials that we have produced are incredibly clear. They are unambiguous. They provide information to women in a way that identifies, I suppose, what the limitations of screening, perhaps. Nobody really fully understood that, I would guess. And even looking at the before and the after products, there's no comparison between the two pieces of information. Online resources then have been vastly improved. I mentioned earlier on, since we put the new information on our website back in September, October of last year, there's been 165,000 or more visits to that website. Feedback from patients that we have received is really positive. But this is something that we keep under review. This isn't something that we've just done as a once-off. And I think it's really important to say that as regards all of the recommendations that Dr. Scally made in his report, this is a huge piece of work that's taking place alongside everything else that we're trying to manage and all of the challenges that my colleagues have described this morning. I think we have to start looking to the future in all of that. So with the information leaflets, with the deficits that were there in the type of information and the amount of information we were giving to people, I think we've done huge work in that. And there's lots of other work that's underway as well. So I suppose all of this information is readily available on our website. Women will get information when they're called for screening. They'll be given different information than when they actually attend for their screening test. And it's really good information. And Dr. Scally actually, part of the work that we've done over the last number of months, and we've engaged quite significantly with Dr. Scally and his team in reviewing all of the information. And he's given us some really good feedback as to how we can make improvements. So this is something that we keep under review, but I think right now we have vastly improved that information that we provide to women.
Thank you very much, Ms Tate. Thank you, Deputy O'Connell. Now, Deputy Breed-Smith.
Grant, thank you. There was one question I omitted to ask is, in your report, under progress report on internal cancer audits, you talk about how the expert group is looking at processes that should work in the future. But it is not the case that after the Vicky Phelan case last April, the internal audit was shut down, and that since then there's about 250 to 300 women who've been diagnosed with cervical cancer across the country who are excluded from the 221 group. In other words, they haven't had an audit done, they haven't got access to the particular care package that the 221 group have done, and yet it's likely that they have a smear history because the smear test programme was in operation for about 11 years. But was the audit shut down to keep that figure at the 221 and to stop it growing? And are you not deliberately denying women of access to, the full healthcare package, to audit that would then allow them look at their history in the context of what happened to others, and that there could be, given the law of averages, there could be 50 to 60 women out there who are dying or suffering from cervical cancer at the very least, who might fall into the 221 category but are being shut out because you closed the audit and did not replace it. And really, to be honest, nobody ever said there was a problem with your audit. And the way you carried out the audit seemed to be perfectly fine. The problem was that you didn't tell the patients about the results, and that was the problem. So you've shut down the audit, you're looking at a new type of audit, but in the meantime you have this whole cohort who are being excluded. Would you acknowledge that that's the case?
Thank you, Deputy Smith.
Ask Dr. Henry then to speak just on the first piece in terms of women who had cancer who were outside the original audit or been That's been addressed through the Royal College review. So in other words, if there's an outcome there, then that will determine whether or what needs to be put in place for those people.
And the Royal College review has been delayed and delayed and delayed.
I appreciate that, but I'm just to identify where they are. In terms of, I might ask Dr. Henry just to talk about the interval cancer audit group and why that's needed. And Dr. Scally did actually make a recommendation that there were issues with the audit. Just to maybe ask Dr. Henry to expand on that.
Deputy Smith, I think I can't remember the exact quote that Dr. Scally had, but he did characterise this audit as flawed in terms of its design and implementation. It's easy to forget how, as you point out, how the failure it wasn't just the failure of disclosure, but it was the design and implementation of the audit that was found fault at the time. And it was also incomplete in that it didn't include patients who were characterised as having cancer on the NCRI. So if we look at quality assurance, and there's been much discussion this morning at other fora of quality assurance, audit of interval cancers is but one component of quality assurance. Quality assurance of any programme looks at the whole scope, the whole range, the whole pathway of care, from the credentials of the labs to the smear taking, to the communication with women, to the whole range. And the one other component of this is looking at interval cancers, and to learn from this. And we're aware, not just through this screening programme, there are other screening programmes, that there's very little evidence internationally on how they should deal with open disclosure of interval cancers. And so what we undertook to do after the Scally report came out was to look at all 3 cancer programmes and design a look at interval cancers in those screening programmes, bearing in mind that we all want screening to flourish and to thrive, and to women to have confidence in the programmes and to partake in them. And based on the best international advice and the best expert advice we have here in Ireland, to make recommendations as to how we should deal with interval cancers, be they in breast, in bowel, or in cervical cancer. And this work we're undergoing now, it's led by Professor Susan O'Reilly, who previously headed the NCCP, and we're hopeful we'll have an outcome from that in the summer.
Well, you're still talking about a cohort of women who are excluded from an audit and who are likely to have had a screening history that should be examined. And what is the answer to them? They're being excluded from a group that has access to a certain healthcare package that is, you know, in the case of Vicky Phelan in particular, is proving to be absolutely excellent. And I think it's disgraceful that they're being excluded from that. If they've been diagnosed, they haven't had the audit, they should be included into it. But I just want to take up what you said there about it being difficult to know how to inform women or patients of results. There is a step-by-step guide available on the NHS website, I'm told. I haven't looked at it, but I believe it's very good and very considerable. So what is the problem, therefore, other than you shut down the audit in order to exclude others, to stop that number growing? 2 to 1 remains 2 to 1. It doesn't become 421 or 491, whatever. I think that's pretty disgraceful if that's the truth, and that's what it's becoming more and more look like, particularly when you report that your audit proceedings, you're sitting down with committees and with groups to find out what's the best type of audit. There is no proper audit there to look back at their screening history.
My understanding, Deputy, is first with regard to the provisions given to the 2-1 group, that was in recognition of the fact that there was failure of open disclosure to those women off the audit. But to go back to my point, is the audit was paused, not in any sense, as my understanding was, not in any sense to deny anybody else access to those supports, but because there were faults in its design and implementation, and it was incomplete. That's why it was paused. And you referenced
a whole year.
If I could just finish, Deputy, on the point of England and Wales, I visited Public Health England, and you're absolutely correct. There's been guidance in place since 2016 in Public Health England with regard to communication of interval cancers. But other healthcare systems, Germany, France, Australia, looking at other cancer programmes, do not have and have no active policy on open disclosure in interval cancers, because they're population screening programmes. So there's a variation of opinion on this issue internationally, and what we want to do here in Ireland is design something which will enjoy public confidence and will also allow the screening programmes to thrive.
Well, I contend that you're doing a big disservice to a cohort of women who are suffering at the moment by not having an audit in place that will sufficiently address their concerns about their screening history. And that if you don't have that in place, the only thing I can conclude from it is that you don't want that figure to grow. And this is more lack of open disclosure, if that's the case.
Well, in this, what I described, Deputy, in us looking at interval cancers, we've actively included patient representation in that group, and they're contributing to that work. So, and those patients understand, as we do and as you do, the importance of public confidence in screening programmes. And that involves public participation and quality assurance of the whole range of screening activity.
I understand that, but you say in your report that you have independently chaired, made up of clinicians, patient reps, public health professionals, medical bodies, and it has met 4 times to date. This is a whole year ago, and there's 250 to 300 women diagnosed with cervical cancer since. If I was one of them, I'd be really feeling let down by the state, by the system, by you, by everybody, that there isn't an audit available of my screening history in this context. 4 meetings in a year to decide what to replace that with. It's not acceptable.
Deputy, just say those groups are only created on the back of Dr. Scally's report, so they're only in place for a number of months. So they're deliberately set up.
It's still not acceptable.
But we must make sure, Deputy, we get it right. Like we've made, the previous process.
But you can't be reinventing the wheel. You keep quoting other systems, other countries, Australia. Look at their models and adopt one of them.
That's what we're doing.
Or at least reopen the audit you had, because it served some purpose.
But, Deputy, it was flawed, and Dr. Scally was very clear.
The open disclosure was the flaw. The lack of open disclosure was the flaw, not the audit itself.
Yeah, Dr. Scally did say that, but sorry.
Could I ask a question? Is in relation to audit? Audit is done for quality assurance. Obviously, it's to see if your system is working. Is there a place for anonymous audit as opposed to named audit? Would that be easier to manage? Would it give you the same information in relation to quality?
The expert group, yeah. So,
Deputy, other healthcare systems have audit and have anonymised audit, and while it's very difficult for us to look at this through the prism of our own experience here the past year, in other healthcare systems where they didn't have that experience, they consider that screening is outside what would be called the expectations of a diagnostic pathway. So they carry out, some systems carry out audits of interval cancers, but they're anonymised because the primary purpose of the audit is to inform the quality of the programme.
And is that a system which is better or worse? Because it was the failure of the named audit here which led to the controversy.
Well, the purpose of audit
is to inform quality, because no screening service is 100%. So you're always going to miss somebody. Unfortunately, you're going to miss somebody, a number of people. So if you have 65,000 people who've benefited, and you have 221 who had their smear upgraded on the audit, the system is obviously working if you compare 600 or 65,000 to 221, or maybe even 1,800, as the case may be. But the audit is to learn from, rather than to be an adversarial system.
Correct, and as we've heard today, and there was useful discussion today in other fora about the expectations of screening programmes. They don't, and they're not set up, and they're not designed to diagnose all cancers. Part of the relative risks and benefits of a screening programme is you are persuading healthy people to undergo a test and identify something before a serious intervention or before life-threatening illness develops. But in doing so, the test can't be overly sensitive that you're then going to subject many people to unnecessary tests, investigations, and possibly adverse events. So other systems, our group would be looking at this, comparing other systems. We'll be looking at the relative need to allow a screening programme to thrive and flourish with the expectations that people have about interval cancer audits as part of the quality assurance programme and what they need to be told. And it is not an easy question, and other healthcare systems are facing the same question and are looking at great interest at the problems we face here, and there is no easy answer to this.
Okay.
Briefly, if you...
Yes, Deputy.
Sorry, I know you're a long time. In terms of the audit, my understanding was, and doubt I'm wrong on this one, that the trigger for audit was having cancer. And then we were missing a chunk of people that were on the National Cancer Registry, and we're sorting that out. But in terms of commentary, because I'm really, you know, on one hand we've people talking about populism and scaremongering and then contributing to it, and really feel strongly about, you know, dealing with this situation moving forward, that, you know, lives are saved ultimately and outcomes are better for women and for families. The audit was flawed in its essence, in that, from recollection at this committee, no one ever considered what to do with the audit results, which is a fundamental flaw of any audit. So the audit process, although it identified the 221 women who then received a package based on non-open disclosure, in terms of falling within, and I believe we have been told this many times here because I've questioned it, falling within the acceptable parameters of testing, the 70 to 80%, we have no evidence to date that any lab was underperforming. Would that be true to say?
And just on the laboratory aspect, Dr. Scally was very clear with us, and this was important before we renewed the contracts, and his report actually stipulated this, that there was no reason why we wouldn't renew the contracts in order to ensure continuity of the programme. And if you roll back to the end of last October, if we couldn't renew the contracts, we wouldn't have had a programme, but he made his decision independently of that, and then we moved forward, and obviously we still face some challenges.
Dr. Scally said to me we'd no other choice but to renew the contracts. He still had lots of doubts about the quality of the performance of the labs.
And all I can say from my discussions with him in relation to, there are areas where he identified clear scope for improvement, both within the programme and within laboratories. But what he said is, in terms of the parameters for performance within the laboratories, because I mean we had this direct conversation, and it's in, I think, even in the report in relation to, in his report specifically, there was no reason not to do that. That doesn't mean there aren't things that we need to tackle, like there is with any provider, and both on our side in terms of cervical check and also within the laboratories themselves.
Because there's been internal, when I talk about the IOS or ISO, I can't remember now, accreditation, and the American labs, there's internal audit processes and QA procedures in labs to make sure that they fall within the correct parameters. I understand. Wouldn't that be the case?
Yes, I mean, in terms of all laboratories have an accreditation standard, all laboratories would have their own quality assurance, and we have a level of quality assurance which is fairly standard, and as Lorraine has identified earlier, our new pathology lead is updating that standard to strengthen it. That doesn't mean, for example, as I said, Dr. Scally is doing a follow-up report in relation to the laboratories, that there aren't issues that we need to tackle, and as there would be with all laboratories on an ongoing basis, and we'll continue to do that and work closely with him and his team on it. We met them last week.
So in terms of the halting of the pausing of the audit process, really it's not true to say that people have been left out, or there's been any shutdown, or that people have, I don't want the message going out that there's some people out there that for some reason aren't getting treatment because the audit process was up, because that's just not the truth.
There's a lack of audit, not because of the audit, the lack of it.
Just to make sure it's clear what's going on.
And there is no impact on people's care. I think that's important. But notwithstanding, I accept Deputy Smith's point that we do need to get to a point where we have a defined audit process. I mean, you described yourself a range of options that are there in different jurisdictions. The point of a group, an expert group, with patients involved at the heart of it, with professionals and with providers, is to make sure we come up with a model for audit that will work for cancer, for the screening programme, but also for the person themselves. And we need to do that, and do that expeditiously. That was put in place, I think, in December, following Dr. Scally's review, and they've met, as I said, on a number of occasions already. So.
And in relation to the 221, is it true to say that a significant number of those, perhaps even a majority of those, have had their cancer successfully treated and are not in any way in a situation where their cancer is untreatable? They have been treated successfully, many of them.
Deputy, working and in collaboration with the 221 group, an audit was carried out of the current state, and I can't recall the exact figure. I think it's 179 are considered disease-free. we can provide further information to you.
I think the report was circulated to the committee. We did an update on the condition for the 2-to-1 group, which we provided to them and then circulated to others. But just to be clear, I don't have the numbers to hand, but I've met with many of the group, and that's not to say that many people don't face, emotional, psychological and other impacts from their cancer. If you put 221 women and their families, remembering that some of those people were deceased, into a room, the impact of cervical cancer is very stark, irrespective of anything to do with audits and the impact on people. So we recognise that, but the report set out the clinical condition for people, and that was published, and we did that in conjunction with the 2-to-1 group. We did that together and published it together.
Thank you very much. So we've been here 4 hours now. I think it's time to conclude. Thank you very much for those who've contributed, but also thank you very much for coming in to give us an update on the backlog, which hopefully will be cleared in the not too distant future, and also on the timeline for HPV. So Michelle Tate and Mr. McCallie and Dr. Colm Henry and Dr. Lorraine Doherty, thank you very much for coming in. This committee will now suspend until, I think it's the 8th of May. We have 2 select committees coming up next Wednesday and Wednesday week. Then there's an Easter break, so the joint committee won't convene again unless something unusual happens until the 8th of May. Thank you.